All right. So, as we all know, schizo is also one of the most common conditions or one of the mental health or psych problems that we do encounter it in our NCLEX and even in daily practice. If you're a nurse or our mental health nurses will tell you that it's also one of the common conditions that they do encounter on a daily basis. Basically, schizo will affect the individual's level of thinking, that is thought processes. That is what mostly it affects. So it causes distorted thought processes. It disrupts the individual's daily activities in terms of interpersonal relationships. Some of them will also have issues with the way they think, okay, in terms of delusions and hallucinations will all come in. It also affects the individual's mood, behavior, and then how they perceive things all get affected when one is affected with what we call schizo. The cause of schizo, a lot of them could be family, history. Someone is born, there is a history of, schizo in your family. The person can pick it up later on in life. So genetics play a role. Brain chemistry in terms of an imbalance in what we call neurotransmitters, like what we call dopamine, can equally lead to what we call schizo in life. Then, when you also have some environmental factors, especially during what we call prenatal exposure to toxins, viruses, and stress, and all that could equally affect what we call the fetus, and later on in life, the child will develop some form of mental health problems like schizo. Now, it comes to schizophrenia. When it comes to the management, we all know that basically we use our antipsychotics to help control what we call symptoms. One of the typicals that are mostly used are Haldol, haloperidol, and other atypicals and atypical antipsychotics that are used in managing what we call symptoms. Today, we are not doing pharmacology. I've done pharmacology not long ago. We'll go back to it again. But if there's a need for me to do the farm as part of the what we call mental health, we do that. Then supporting the what we call the patients in terms of behavioral therapy, and then assisting the person to achieve certain form of um, um, usefulness in terms of performing activities of daily living and all that. Nursing management will also come in. So generally, when it comes to schizo, that's just a brief overview of it. Now, what we need to understand is that when someone is affected with schizo, what are some of the things that we will notice that this person is behaving abnormally? And it is not depression, neither is it mania, even though people with mania can equally present with some of these symptoms. Okay, so we look into it. So my assessment, I have grouped them into cognitive symptoms, into negative, into positive symptoms, and those that shows the depressive symptoms as well. So the cognitive symptoms will talk about the way what the individual thinks. So the level of thinking of the individual, how does it affect, or what are some of the things that happens to the individual, someone who has what we call schizo. So people with schizophrenia, in terms of cognitive symptoms, they will have what we call illogical um, thinking. The way I and you, we can think straightforward. If the thing is one, we can say it is one. For them, they can see something and misinterpret it in a wrong way, even though they can see what we call a stick and then misinterpret a stick to be something else. And so they have illogical thinking, and the way they think too is not as coherent as myself and your own will be. So that is illogical thinking. They have impaired judgment. The way they judge things, or their judgment is very bad. They have impaired judgment. They have impaired memory, as well as inattention. They easily get distracted. Have poor attention, decision making skills. Their ability to make decisions becomes affected. And so you get to understand that at a point you would have to even stay and then make decisions for the client when you need to make decisions. For those that their ability to make decisions becomes affected, then they have poor problem solving skills. So all these symptoms falls under cognitive, the way the person thinks, and then because you need to think and act or solve a problem. So if cognitively you are affected, then these are the areas that is going to be affected. Then we have the positive, negative symptoms. But these two things, you cannot learn schizophrenia and say that after learning schizophrenia, when they ask you about, symptoms in terms of grouping it into both positive and negative, you say you don't know. You'll be able to know these two. If you forget about the cognitive symptoms and then probably the depressive symptoms, you cannot forget about what we call them, the positive and negative, because the NCLEX, they like asking those things. So that if you get a question, a case study, they ask you to group what we call the assessment findings into positive and then what we call negative symptoms. So positive symptoms, they mostly affect what we call the individuals, or they are symptoms that they are added to the individual's original behavior. And so the positive symptoms are those that involve an addition to an unusual behavior or experience to the person's normal life. So most of these things comes in as a result of the person's condition. So for instance, when you take something like hallucination, we know that when it comes to the hallucination, the person has a problem with the way they start to hear things. The five senses are mostly affected. So we have auditory hallucination, we have tactile hallucination, and something new is added, or a new problem is mostly added to the individual's behavior. Okay, when you take delusions, the person starts to perceive themselves as in a wrong way, or let's say you take something like persecution or delusion of persecution. The person always think like someone is thinking to harm him or her. And so there is something new that has been added to the individual's behavior. So positive symptoms, we have bizarre behavior, we have delusions, we have hallucination, and then we have this organized speech. So these are some of the, or these are the positive symptoms when it comes to schizophrenia. At least our delusion, hallucination, we have to have it at the back of our minds that it falls under what we call positive symptoms. And like I said, when it comes to positive symptoms, it's like something else has been added to what we call the individual's original abnormal behavior that they are showing, or the individual's behavior. Then when you take the negative symptoms, this time around, nothing has been added. However, the person gets diminished in terms of certain things that they should be doing under normal circumstance, or in their day in, day out activities, certain things that the individual should be doing. Then the person gets there is a reduce in terms of those behavior or those activity. So you have something like, at least as we are there, once in a while you'll be happy, you have the motivation to do something. But this time on, that kind of motivation or that kind of joy that you need to have to do certain activities reduces. And so you tend not to do those normal activities again. So we have blunt affect. Nothing makes the person happy. It's like the person just living nothing. The person nothing moves the person. We have inability to experience what we call pleasure. That is anhedonia. In fact, we need to know these terms. That's why I explain and then put what we call the actual term there. So when you take anhedonia, lack of what we call pleasure or joy, or inability to experience what we call pleasure, is what we call anhedonia. And so we need to have that kind of motivation or that kind of joy that we need to experience it day in, day out. But for these people, they have what we call a reduction, or they have a reduction in terms of what makes them happy. So and nothing makes them happy. Okay, then we have loss of what we call motivation. So they also have lack of motivation. That is also evolution. So nothing also kind of motivate them. But when we wake up every day, we get certain form of motivation. For instance, we are all preparing to write the NCLEX. We all have reasons why we've set the goal to write our NCLEX. But these people, so that kind of motivation motivate us to wake up every morning to study. Or we go to our books to study because of certainly instincts that motivate us. Okay, but these people, they don't have, or they have a reduction in that. And so you realize that if they used to study, that kind of, the thing that will motivate them to go and study will no more be there. So there's lack of loss of motivation, which is evolution. Then we have alogia, that is poverty of thoughts. So this time on, they get affected in terms of what we call speech. So that is the negative. So we have the negatives there: plant affects anhedonia. Then we have loss of motivation. Then we have poverty of thought, that is alogia. Then we have what we call the depressive symptoms and other symptoms that can also follow people who are having what we call schizophrenia can equally exhibit. We have hopelessness. As we all know that people who are depressed, they have hopelessness. They think that nothing moves them. And if the person becomes hopeless at the end of the day, in depression, we say that they are more susceptible to what we call suicide, or suicidal thoughts increases in what we call people who experience depression. So for those with schizophrenia who have what we call depressive symptoms, these are some of the things we have. They have dysphoria, they have hopelessness, then they also have what we call suicidality, or they have what we call suicidal thought or ideations are mostly common with these people as well. So these are the classifications or the various symptoms that people with schizophrenia will experience. That is not all. We also have the abnormal motor behaviors. Okay, abnormal motor behaviors that people with schizophrenia are also mostly affected with. And so you see the person, they tend to assume a certain posture for a very long period of time, or for a very long hours. Then you see the patient assuming that kind of position. Okay, you see some people, they repeat what we call the speech of others. Others also repeat what we call movements of others. So we need to know the terms that represent each of these things and then how to explain it. Now, when it comes to the motor behaviors, so the abnormal motor behavior or activity, that is mostly displayed by a client with mental health problem that occurs as a result of mental health disorder. So these people tends to have what we call abnormal motor behavior. Okay, and it's as a result of their mental health problem. So people with schizophrenia, what are the abnormal motor behaviors that they exhibit? So the first one is echolalia, repeating the speech of another person. So I am a nurse, I am attending to the client. Instead of the client listening to me, whatever statement I make, the person tries to imitate and repeat and make the same statement or repeat the same statement. Or you are in the midst of, the patient is in the midst of people talking, try to also repeat the statements made by other people. So repeating the speech of other person, it's also an abnormal behavior that people with schizophrenia mostly experiences, and that is echolalia. Then we have echoplexia, which is this time around the person is not repeating speech, but rather repeating what we call movements. So whatever movements one makes, the patient makes the same or repeats the same movement. So repeating the movement of another person, it's also an abnormal motor behavior, mostly exhibited by people with a mental health problem. Then we also have WASI flexibility, which is quite common. Okay, that you see the person having a part of their body placed in a certain position for a very long period of hours. So having one's arm or legs placed in a certain position and holding that same position for hours. And mostly when you are probably in your car going somewhere, you see someone with a mental health problem standing at one position and then holding that position. You go and come and the person is still standing there with such same position. And that is what we call waxy flexibility. So having one's arm or leg placed in a certain position and holding that same position for very long hours is what we call waxy flexibility, and it's also part of what we call the abnormal motor behaviors that people with what we call schizophrenia mostly experiences. So that is on abnormal motor behavior. Now let's talk about abnormal thought processes. So abnormal thought processes deals with the way the person thinks, the way the person thinks and makes up what we call things, okay, the way they think, thought process, the way they process ideas and information. So this one to also displayed by people with what we call mental health problem. The first one we talk about is circumstantiality. So we need to understand at least word salad, confabulation, flight of ideas are quite common. You get to meet a lot of questions on what we call flight of someone says that it's common in those who take red. Okay, all right. When you've read, that's just by the way. So the first thing we talk about in terms of the thought processes is circumstantiality. I was making a statement that word salad is one of the common areas you meet in the English, okay, as well as neologism, and then other one or two of them. So the circumstantiality is when before getting to the point of answering a question, the client get caught up in countless details and explanations. So you are talking to the client, you've asked the client to explain something to you, or you've asked a question. The person is just about answering the question. The moment the person started answering the question, at the point the person is answering the question, the person gets caught up in countless details and explanation. You see that something that demands just a straightforward answer or a yes or no answer, the person will be giving you plenty background to whatever you asked and plenty explanations and details. Probably you needed just a straightforward explanation or answer. But this person will give you, plenty details or a lot of information with regards to whatever you were asking. That's the circumstantiality. Then we have confabulation. Now, if you want to understand confabulation, think like the person is lying. Okay. So confabulation is more like the person is telling lies. Okay. Filling a memory gap with detailed fantasy believed by the teller. So the purpose of confabulation is to maintain self-esteem, and mostly seen in people with what we call organic conditions such as um, 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 Korsakoff, what we call psychosis. But we are not going to talk about Korsakoff psychosis, but just for us to understand that it is one of the conditions in which you can easily stop people experiencing what we call behaving or showing what we call confabulation. Confabulation. Like I said, confabulation is like the person is telling lies in order for someone to believe. So we have various types of confabulation. You could have spontaneous confabulation, you could have provoked confabulation, you can have verbal confabulation. And so a person might recall having a steak for lunch when they actually had a soup. So the person ate something, but or let's say the person took lunch, okay, or lunch, when the person took lunch, they gave the person soup, but the person will make up something and tell you that, oh, it was a different food, like let's say fried rice, trying to make it to look as if more appealing, even though that is not what they ate. Okay. Or another example about confabulation is that the person um the person claims that they won first place in what we call competition when they actually came second. And so that is also an example of what we call confabulation. Like the person is telling lies, okay? And so they do that to maintain self-esteem. The person, let's say, wrote exam and then was, let's say, third, fourth. But in order to maintain self-esteem, okay, they come to tell you that, oh, I was the first person. Meanwhile, in actual sense, the person was what we call second or third. But I will come to you and tell you that I was the first person in class after the exam. So that is what confabulation is. filling a memory gap with a detailed fantasy believed by what you call the teller, and the purpose is to maintain self-esteem. Then we have flight of ideas, which is constant flow of speech in which the client jumps from one topic to the other in a more rapid succession. And so, but one thing about flight of ideas, it looks just like looseness of association. In flight of ideas, mostly the topics are more connected to each other. Even though the person does not complete whatever the person is talking about, it moves to a different topic. But mostly the topic the person is talking about, they are a bit more interrelated, or they are more like connected to each other. Okay. And so the person moves from one point to the other. It's like pressured speech seen in people who are in a manic state or mania clients. You know, those people, they talk a lot, they are mostly high, and they are always talking, like they have that kind of pressure speech. And so the person is talking about something, the person will not finish whatever they are talking about. Then the person moves from that topic to the other in more rapid succession. I mean, a connection between topics exists, although it is sometimes difficult to identify the connection. And so let's say the person has woke up early in the morning, and then the person is trying to, or let's say you are discussing something and you are asking the person to tell you what the person ate in the morning. Then the person, while the person is talking about what he or she took in the morning, then you see the person will bring in maybe a dream the person had. You know, I mean, mostly morning activities. I mean, probably the person will try to think about what happened during sleep. And so the person jumps from one topic to the other in a rapid succession. Sometimes the topics that they jump onto are mostly interrelated, or they have a certain form of connection. And that is what flight of ideas are about. Then when we come to looseness of association, it is the same thing like flight of ideas, but this time around, there is no connection between the topics the client is discussing. And so there's, I mean, illogical and confused thinking and interrupted connection in thoughts, seen mostly in people with schizophrenic disorder. Yes, so this person moves, I mean, rapidly moves from one topic to the other, will not complete a statement and move to the other thing. This time around, the topics are not related at all. You are asking the person about maybe activities of daily living. Then the person is talking about something else. The person start on what the person was doing in terms of activities of daily living. And the person jumps from that activities of daily living and start talking about maybe a certain assignments the person was doing. Like it's not related, like school issues. And mostly the things the person will be talking about is not logical. Okay. I mean, that you become confused. But in flight of ideas, sometimes the points are there. You can know that, okay, this is what the person is talking about, just that the person moved from this topic to the other. Like I said, the topics are mostly related. But for looseness of association, you cannot even understand what the person wants to tell you. Okay, but move from that and talk about different things. Then we have neologism, which is the one of the common thing that we all meet. That I mean, someone creating their own words, or I mean, making up words that is only meaningful to only the client. So the client is there, you hear the client mentioning certain words, and you've not seen the word before, neither have you heard the word before, but the client understand the word. Okay, so the client makes up words that have meaning only to the individual, often part of people who have what we call delusional system. That is neologism. Then we have thought blocking. So thought blocking is when you are discussing something with the client. The moment you start a topic, the client start a topic, and then now stop talking, and the person becomes mute. So there's a thought blocking. It's like the person has forgotten about whatever the person was discussing about. The person will have to wait for a certain period of time, and then the topic the person will hook onto will not be related to what the person was discussing initially. And so a sudden cessation of a thought in the middle of a sentence, the client is unable to continue the train of thoughts often sudden new thought unrelated to the topic comes up. So, like I am presenting here now, you know that I'm talking about abnormal thought processes. The moment I start talking about thought blocking, then I stop. And then I'm not talking again. Then it has to take me some time for me to be able to come up with something again. And the new thing I'll be talking about will not be related to the thought blocking, but a different thing. And so that is what thought blocking is. There's that cessation of what we call a sudden cessation of thoughts in the middle of what we call a sentence. Then we have word salad. And so for word salad, we all know word salad, that the person jams up what we call the words. And so mostly the wordings are mostly jammed together. I used to have this example. Yes. So example of word salad, we have something like blue tree, happy singing elephants. I mean, yes, the wordings are there. You can see that the words are there, but for neologism, it's a word that you've not seen before. Okay, but the client will coin that word, and then it's meaningful to only the client. But for word salad, the words are real words. The words are correct in terms of spelling, and then yes. But this time, the way the person is joining the words together, it doesn't make sense. Okay, so dreams spoke organ sunset, another example of what we call word salad. So a mixture of words and phrases that has no meaning. It's what we call word salad. So this time the words are correct, but then the client is jamming the words up, or is adding the words up, and it has no meaning. And that is what we mean by what we call word salad. So these are, I mean, the abnormal thought processes that people with what we call schizophrenia mostly experiences. If you have an input you want to make based on what I have said so far, you can bring it up, and then we'll take it up from there. Someone was asking, is confabulation similar to grandiose personality? Okay, so we are about to talk about, so in grandiose, I'll say that, so in grandiose, the person see themselves like the most significant, most powerful. It's a little bit different from what we call confabulation. So confabulation is more like you are lying. Okay, it's like more of telling lies. Okay, in order to make up for, I mean, memory gap. Okay. So let's talk about delusions. Okay, from delusions, we go to hallucinations and all that. Yes, Madam Sarah.
So I wanted to find out, are they aware of the condition of their situation? Because I was looking at the definitions, and it looks like is that their defense mechanism, like whether they are aware of the situation they are into, and so it becomes their defense mechanism. Like if the client has eaten rice and he said he ate sticks, to make them feel
Yes,
comfortable.
they are aware of their situation.
And so is that their defense mechanism?
Yes, yeah. So when you take something like confabulation, for instance, it's something like a defense mechanism they show. Okay, just for them to look like to help maintain their self-esteem. I don't know whether what the point I'm making. You are getting the point I'm making here.
Yeah.
Yeah. So it's
Hello.
more like, yes, hello.
Master Amigo, please, with regards to her question, it's like that's one of the difference between the psychotics and the non-psychotics. That with the psychotics, they lose sight with reality. So I myself don't think that like they are really aware of their doing or what is really happening. You get me?
Yes. So come again.
So I'm saying that with psychotics, you know, we have psychotic and then non-psychotic, the conditions.
Yes.
And then they are saying that so with the psychotic conditions, they don't have insight. Usually, those people, they don't have insight. So meaning that they don't actually know what is happening to them as compared to the non-psychotic conditions. So they don't actually know like what they are going to. That's my understanding of psychotic and then non-psychotic behavior. The insight.
Yes, I get your point. So examples of psychotic condition and non-psychotic. I threw the question back.
So schizophrenia is psychotic.
Uh-huh.
And
the
then
non-psychotic.
like depression, mania. Those ones are non-psychotic. So
okay,
they still have this inside. They still have that one intact. So they know what is really going on.
what is happening to them?
Yeah.
So that is why they use what we call the defense mechanism to try to maintain or manage their situations.
Yes, yes.
Okay. Let's hear from Mr. Richmond.
Please, I want to clarify with what my brother is trying to say.
Okay.
Because
okay.
We have psychotic symptoms and then neurosis.
Yeah.
So with the neurosis, for them, there's no psychosis.
Okay.
For example, obsessive compulsive disorder and then phobia, because they have with the psychotic symptoms, they lost touch with reality. Hello.
Yeah, we are with you, Mr.
With the psychotic symptom, they lost touch with reality, but with the neurosis, they are intact. They have senses, like they could tell what they are doing. But with the psychotic symptom, whatever transpires, they can't tell.
Okay.
Yeah, that is what I want to clarify.
Okay. Thank you. So they've added up. So that is it. So, but Madam Sarah, these people,
yes, thank you.
They fall under the psychotics, and like they said, they have loss of touch with the reality, so they are not able to really tell what is really going on with them. Okay. All right. Thank you, Mr. Yusuf, and thank you, Mr. Richmond. All right. So that is on the question Madam Sarah was asking, with what we call delusions. Fourth part of what we call the symptoms that people with psychotic conditions like schizo show. They have what we call a false belief held to be true, even though there is evidence to the contrary. So these people, they believe that what they are experiencing is true, even though, there is no evidence to that. And you try to even prove to them that what they are, hearing or what they believe to be true is not true, but they still don't think that that is actually the case. And so we have lots of what we call reference. So in which the clients believe that certain events, situations, or interactions are related to them. Okay. Yes, Madam Carol.
So, okay. So what the other gentlemen were saying, when you were doing the positive symptoms and the negative symptoms, I really took it as for somebody to be declared as psychotic, also somebody to be seen as having psychosis, they will need to have like those 4 symptoms, those positive. So like the positive symptoms actually confirms there are positive signs for psychosis. The signs you gave us, delusion, hallucinations. That is how I even took it. That is how I took it. That is how I understood and took it. Because for somebody, a non-psychotic patient, they can have inability to have pleasure, inability, loss of motivation. They can have all those things. But once you start to have psychosis, once you start to have hallucinations, delusions with a bizarre behavior, then it means that you are positive. You're a positive psychotic patient. Thank you.
Okay. All right. So Madame Karoti is saying that she has given us how she understands positive and negative in terms of what we call that sentence. All right. That's fine.
Hello.
Yes. Madam Mama.
Yeah, she's not alone. That is what I also that is how
Okay.
I also understood it.
That's
Yeah.
also the way you also take to understand it, right?
Yeah. So I was going to ask a question, but my reaction tab is not working, so I couldn't even raise my hand. That's why I just
Okay.
put
Okay.
on my mic. So
Okay.
I am with her. I also took it like that.
Okay.
Yeah.
Okay.
Sure. I also support them, and I want to see, is it like
Okay.
they will have the negative symptoms plus their positive symptoms to determine that they are a schizo, right? Is that what it means?
The reason why I don't want to say yes is that, okay, that is the way, if that is the way you want to take it to understand it, I hope you get the point I'm making. That yes, we have the negative symptoms. Just like I said, that the negative symptoms are something that we all experience. We all experience happiness. We all have the motivation to do something. But we people who have schizophrenia and are experiencing what we call negative symptoms get diminished in terms of those areas. But with what we call the positive signs, it's like something now has been added to the person. And that is what is making us say that the person is having schizophrenia. So the person is now, nobody here will start experiencing delusions, will start experiencing hallucination if you don't have any mental health problem. Okay. But now the moment you start having delusions and hallucination, means that something new has been added to your behavior. That's why I use it that way to explain it. Okay. I don't know if I'm making sense. It's all about how we will all understand it. Okay, you know, when it comes to concepts, everybody has a way they will understand concepts. Yes, there's another hand. Madam Essing.
Is it possible these patients have like the same symptom at the same time, like the positive and negative at the same time? So, like, let's say for a moment they are having this bizarre, very strange behavior, and the next second they are all having like a very flat mood.
Oh yes,
I think it happens.
can have it. They can have the symptoms, but it will not like so like the person will be having hallucination for some time, and at a point the person will start exhibiting maybe some form of anhedonia. Okay, lack of motivation, and those it can happen.
Okay. So, sir.
Always yes. Yeah.
Oh, so sorry if I've been a
Yeah, so
deviant
you always
today.
use the hand so that we can.
Okay, sorry, please. The reason why I took it like that and it's making me understand the tennis. We had a patient, we were managing a patient, and she had all the other negative symptoms. The lack of pleasure and all that. She had all those things. And nobody diagnosed her as being psychotic. She was being handled like a normal patient.
Medical
We know
case, okay.
a normal medical case. We know she has got mood issues and all those things. But suddenly she started telling me of seeing somebody telling her he will kill her, somebody saying something, and she'll point to the wall and say, I should see the person standing there. So I went to tell the medical doctor that our patient is starting to hallucinate. Then they changed her management from medical to psychiatry.
Yes.
They had to bring in the psychiatric personnel and all that
Yes.
because she
I
has showed the positive psychotic
I
sign.
understand you
Yeah.
very well. I understand you very well, Madam Karen. Yes, Mr. Richmond.
Okay. Please, I want to clarify with what my sister is saying. You know, with schizophrenic patients, they need to have both positive and the negative symptoms.
Okay.
And with the treatment, when the client is being put on the medication, the positive symptoms has to go,
Yeah.
but the negative symptoms are still there. That is why with the schizophrenia, if you look at the types of schizophrenia, you get a residual schizophrenia. That means that the positive signs and symptoms are gone, but the negative signs are still there. And these are the loss of interest in daily
Yes.
activities. It will still be there.
Yeah.
Unless maybe you have encounter with the client, you wouldn't know that the client is exhibiting it. Unless maybe you know the client from day one, the person who used to like some activities like football or watching of movie, and because of the condition, now the interest for those activities has been diminished. Thank
All
you.
right. All right. Thank you. So just like I said, it is just what Madame Carey is saying. Yes, it makes I mean, it gives you the understanding that we use the positive symptoms to kind of confirm a client's diagnosis that the person is having schizophrenia. But if that is the way you take it to understand it, that's perfect. Okay, that's perfect. All right, so let's move on. So when it comes to delusions, so I was on what we call loss of reference, where the individual believe that certain events are mostly directed towards them. And so, for instance, you are having a discussion, or there is, let's say, a radio ongoing, or let's say that there's a radio in a client's midst, and then maybe they are having certain discussion, and the client tends to think that whatever discussion they are having, it's directed towards the client. Okay, that is what the loss of reference is. So the client believes that certain events or situations or interactions are related directly to them. Probably you are there discussing something with someone else, and then the client sitting there thinks that whatever you are discussing is related to, him or her. Then we have delusions of persecution, where the person always thinks like people are plotting to harm him or her. So the thoughts that one is being singled out for harm by others, in which the client believes that they are being harassed or threatened or persecuted by some powerful forces. So mostly the most one of the examples that you mostly see is so that someone is thinking that the CIA is or FBI is after the person, and meanwhile, there is nothing like that. The person thinks like the police people are after him and looking for him to arrest him. So the client will come to you, or client will make such a statement that the police is after him or CIA is after him, looking for him to arrest him. Okay, so that is what persecution is about. Then we have what we call grandiose. So where the person always think like they are the most powerful and then most important person. So the person attaches what we call significance, special significance to self in relation to others or the universe, and then has some form of exaggerated sense of self that has no basis in reality. So the person always think like they are the most powerful if they are in a group, or the person always think like I am the boss. Okay, that kind of bossy behavior. People with schizophrenia will always have that, or have that kind of delusion that is grandiose. Then somatic delusion, like we discussed last week, that in somatic symptoms, the person always think like has some form of physical symptoms, but there's no an underlying cause of their physical symptom, or there's no physiological cause of the symptom the client is showing. And so we have somatic delusions in which the clients believe that certain part of their body is changing or responding in an unusual way, and there is no basis for what we call this, that what the client is telling. So the client first tells you that my leg or a certain part of my body, it's responding in a certain way or in an unusual way, okay, or complains that maybe the leg is hurting But you go in there, you do your assessment and you realize that there is nothing there. So that is also what somatic delusion is about. When it comes to delusions, we all know that in delusions, we say you present reality to your clients, right? So these people, they have a false belief, okay? To them, the thing is right, or to them, it is correct. So you don't force them to believe that what they are experiencing is not true, or what they are experiencing is false. Don't force them. Present the reality. Let them know that what they are experiencing is part of their condition. And it is as a result of that, that is why they are having such, delusional thoughts. Then present the reality to them. So let's say the client tells you that the CIA is after me. Let the clients know that, yes, I understand that you believe the CIA is after you. However, it is not true that in reality, the CIA is not looking for you, or no one is looking for you to arrest you. Present the reality, acknowledge the client's, behavior, or the client's expression or feeling, and then present what the actual truth is. So for these people, you ask them to describe what the delusion is to you. So if you notice that someone is, experiencing delusions, you ask them to describe the kind of delusion or what they are experiencing. Then you be open and honest to them in your interaction in order to reduce what we call suspiciousness. So it's something like delusions of persecution, where they always think like people are always after them, or someone is after them, looking for them to harm them. You need to be honest with them in your interaction in order to reduce that form of suspicion that they have. Then you also encourage the client to you focus on reality-based topics, okay, rather than the delusion. So like I said, you present the reality to them. You let them know that this is the case. What you are experiencing is part of your problem, but in actual sense, this is what the problem is. Yes, is it a new hand?
Yes, it's me. Listen. Please, can these delusions be related to other conditions, not maybe not schizophrenia or mental? Because I once witnessed someone brought to our facility for taking marijuana for the first time. For the first time, and then the person was holding the left hand, and that it was chopped off. That's what he was saying. So with this, I think one can classify that as somatic delusion. But then, can we say that in that case, marijuana can cause this schizophrenia or psychosis?
Yes. So in that instant, that is the substance abuse disorder leading to the person having hallucination. Having the delusional, thoughts, or having delusion. But we don't say it is schizophrenia the person is experiencing from.
Okay.
I hope you understand the point I made. The intake of the drug is leading to the person experiencing the delusions.
The delusion.
It is not what we call schizophrenia. In that instance, you don't say it's schizophrenia. Yes, the person is experiencing delusion, but the cause of his delusion is as a result of the drug abuse.
Okay.
So we're doing the what we call the intervention. So I was on the fact that I need to let them understand what the actual reality is. We focus what we call encourage the client to express their feelings. We encourage them, and then you also to focus on feelings that the delusions generate. So you have to understand what mostly precipitates what we call the delusional thoughts. And then if the client is more obsessed with the delusions, you need to set boundaries. These people, you need to set boundaries on the amount of time they will spend talking about what we call their delusional thoughts. You do not also have to argue with them or try to convince them that their delusions are false. So like I said, don't force them. The client doesn't believe what you are saying. Just present what is the truth to the client. Okay. Don't force them unless the client's behavior is becoming abnormal. That is where we are even like becoming more aggressive to self and others. You need to set the boundaries and all that. Especially that mostly happens in what you call hallucinations. So we'll talk about hallucinations very soon. You do not also, so you need to validate if the part of the, which part of their delusions, is real. Even though we are saying that most of the things they tell you, to them it is true, but then, in reality, it's not the truth. But even though, so for instance, somatic delusion, for instance, client tells you that, a certain part of my body is behaving in a certain way. You don't just sit. That is why you need to validate whatever the client is telling you to see what, if indeed there is no cause of, what the client is telling you. So you need to validate, if there is a certain part of the client delusional thoughts that is real. So that is on delusions and then how it goes. Now we'll look at questions on delusions and then probably will help us to also understand. Then we also have another form in which we can classify the symptoms of what we call, schizophrenia. That is perceptual distortion. Okay, perceptual. So under perceptual distortion, we have illusions and then we have hallucination. In illusions, the person, misinterpret or misperceive a reality. So like when I started, I used something like a stick, for example. There's a stick lying down. Yes, we all know it is a stick, but the moment client spots it, the client thinks that the stick there is a snake. Or there is a certain wall clock on the wall. There is a reality. In reality, yes, there is something hanging there, which is a wall clock or a wall frame. But the client sees the wall frame and see that to be like a bomb or grenade. So the client is misinterpreting the reality, or so, which may be brief experience with misinterpretation or misperception of reality. So a client sees something in reality, which we all see that the thing is there, but how the client misinterpret the thing wrongly, that is what you call illusion. So illusional thoughts falls under what we call perceptual distortion. Then we have what we call hallucination. So hallucination to the client. So sense perception, it occurs with one of the five senses for which no external stimuli exists. So this time around, the client is experiencing certain things, but there is no external stimuli to what the client is experiencing. For instance, the client tells you that I am hearing certain voices, but within the client's environment, there is nobody there sitting and talking. Okay, there is nobody in the client's environment talking or telling the client to do something, but the client is telling you that I am hearing certain sounds or certain voices that is commanding me to do certain activity. So the client is now misperceiving certain thoughts in which in reality that thing is not there, or there's no an external stimuli to what the client is thinking about. So this affects the five senses. We have the auditory, we have gustatory, we have olfactory, we have tactile, then we have visual. So I think the most common ones you get a lot of questions on would be auditory hallucination and then visual hallucination. And so in auditory hallucination, which is mostly the most dangerous form, where the client tells you that I am hearing voices that is telling me to do something. Okay, so hearing voices when none are present. So like I said, client is experiencing certain or is hearing certain voice, but there is no an actual, cause, or nobody's in the client's environment, immediate environment talking to the client. Then another form which affects taste is what gustatory hallucination, where the client experiences taste in the absence of external stimuli. Client is not taking anything. The client hasn't taken anything. My client is telling you that I'm having some form of taste. Okay, that is gustatory. We have olfactory, that is smell. So the client tells you that I'm smelling something, but in actual sense, within the client's environment, there is no form of, nothing. Like client tells you that I smell like petrol within my, environment or within the immediate environment. Client tells you that, he can smell petrol, but you search around, there is no petrol. Okay, that is what we call olfactory. Then tactile has to do with movement on a client's body or sensation. So feeling of touch. So feeling touch sensations in the absence of stimuli. So the client tells you that it's like something is moving on my body, but in actual sense, there's nothing on the client's body. Then the next one or the last one is visual. So visual is client tells you that I'm seeing certain things, but there's nothing in the client's environment that client tells them, okay, I'm seeing some people holding guns. Meanwhile, in the client's environment, nobody is there with a gun. The client tells you that I can see that people are coming after me with guns and all that. So that is what visual hallucinations are also about. So these are the 5 types of what we call hallucinations, and then how to explain or understand them. Okay. When it comes to hallucination, you need to ask the client directly about the form of hallucination they are experiencing, especially auditory hallucination. Ask the client about what the voices are telling them to do, or what the command voices are telling them to do. You need to validate what the command voices are. So ask the client directly about the hallucination. Avoid touching them. These people may misinterpret, avoid reacting to the hallucination if it were as if it were real. Okay, so trying to poke more, trying to react, or let's say client tells you that I am hearing certain voices, and you are trying to react to what we call that form of hallucination the client is experiencing, as if it is actually true that the client is what we call experiencing what we call or there is that thing in the client's environment or stimuli. You have to avoid reacting to what we call the hallucination. Yes, take it serious that the client is telling me that something is telling me to harm someone. Take it serious and set boundaries and show safety. But don't try to react to what we call the hallucinations. You need to decrease stimuli or move the client to another area. Especially if the client tells you that I'm hearing voices or I am seeing certain things. You need to ensure safety. And in doing that, you need to decrease any form of noise or any form of stimuli within the client's environment. Then, or you can move the client to another area, especially if the client is in the midst of other people, like in a group therapy or in a group session. A client tells you that I'm hearing certain voices. Safety is important. So you need to move the client out of the other people, or you move the group and leave the client alone. You do not negate the client's experience. So that's what I was saying, that don't just overlook what the client is telling you and leave the client out. It's part of your condition. So it's normal. It's not normal. By the time you realize the client has taken something to choke someone. So always do not or don't negate the client experience. You focus the client on reality-based topics. You present the reality to them, let them understand that yes, they are hearing those voices, but there is nothing in the client environment telling the client to do so. Attempt to engage the client in what we call client attention through a concrete activity. So engage the client in other form of activity. It could be like playing some form of game with the client, or puzzle, or gameplay, certain form of activity that the client can focus their attention on, instead of what we call focusing on the hallucination or what the voices are telling them to do. You need to respond verbally to anything real that the client talks about. Avoid touching them. So we don't touch these people anyhow. Okay, avoid touching them. But when you touch them, they may misinterpret their touch, and then like they are hearing voices that they should do something, or someone is having what we call tactile hallucination. And so you need to make sure that you are avoiding touching as much as possible. Monitor for signs of increasing anxiety and agitation, which mostly indicate that the hallucinations are increasing. These are what you do for people with what we call hallucination. Then the other form, I think I've gone through this with us, in terms of the thought processes that mostly are affected. This, it's also falls under language and communication disturbances for people with what we call schizo. So these people, they have alogia, poverty of speech, or where the person has a reduced volume of, or lack of spontaneous comments, and then they are mostly, they give you brief responses. Okay, then we have associative looseness. We talked about it, that there's disjoint, connection between whatever the client is telling you. They hook from one topic to the other, and mostly what they talk about is mostly not connected. We have clang of association, where the clients mostly repeat the words or phrases that are similar in sound, but in no way other. So, the clients kind of repeats certain words that have similar sounds, and they repeat that. That is clang of association. Then we have echolalia. We've talked about it, repeating words or phrases. We've talked about mutism. Clients remain silent or absence of verbal speech. And with all nurse clients who are mute or who are experiencing mutism before, you try to engage them, talk to them, they don't even mind, they won't even make a word. That's mutism. Neologism, we've said that coining your own words or creating your own words. Then we have talked about pressure speech when we're talking about mania and pressure speech, like the person speaking words as if they are forced to speak. Excessive preoccupation with. Then we have religiosity, which is more of like the person is more preoccupation with religious thoughts or ideas. So all the time the client is praying, the client, I think we've all seen it before, people with that kind of psychotic behavior. Some of them, you see them all the time, they are praying. That is what we call religiosity. Then we have tangentiality. That is a digression from one topic to the other without completing the thoughts or reaching a completion. Verbigeration, repeating words or phrases purposely, purposelessness. So there's no, reason for the client to be making those words. The client will be repeating the words just like that. The word salad, we talked about it, that, jamming words together. Yes, they are actual words. The words are correct, but this time out, the client is just jamming the words, and there's no meaning to, the way the client is adding the words together. When it comes to general interventions for schizo, we've said that safety is first, or safety first. Make sure that the client environment is safe. So you maintain a safe environment, you limit or you set boundaries, set limits on the client's behavior if the client is unable to do so, especially when the clients, when it interferes with others and then it becomes destructive. You need to, set limits, assess the client's physical needs. Very, very important. You need to make sure that you are meeting the client's physical needs, diet, activities of daily living, you are meeting it, hydration, you are meeting it. Then one-on-one interaction before you can move the client to a group therapy. Imagine someone experiencing what we call hallucination, auditory hallucination, and you move the client into a group therapy or a group session. Clients can harm someone. So you need to have one-on-one interaction before you progress the client to small group as tolerated. Then you need to monitor the altered thought processes, set boundaries on the client's egos, and then avoid touching the client. We've talked about it. Then you have to also avoid, overly warm approach. You need to have, a neutral kind of, approach to the client. Don't always accept that whatever the client says, it's true. Whatever the client says, you want to accept that. So that means that you are becoming more, even if the thing is not true, you try to say that the client, try to say it is true. So you need to have a neutral approach to the client. If the thing is yes, say yes. If it is false, say false. Then that is why you need to do. You need to be honest with the client. Then do not also make promises that you cannot keep, especially those with, paranoid behavior. You can have, paranoid schizophrenia. So people who are paranoid, we know they don't really trust a lot. So these people, you don't make promises if you cannot keep your promise. Okay. Then you need to establish daily routines with the client. You assist the client with, grooming, and then a client also accepting what you call responsibility to take care of themselves. You need to provide brief, frequent contact with the client. You need to limit the time of interaction with your clients. Don't spend too much time with them. You have to be brief with them. However, that should be more frequent. So you need to, attend to them more frequently, but don't waste too much time on them, okay, in terms of your interaction with them. But you need to frequently probably visit them, maintain contact, and be brief with it. You need to tell the clients when you are leaving so that they will know that, okay, that is where the honesty comes in. Tell the clients when you do not understand what the client is saying. Then you do not go along with the client's delusional or hallucinational thoughts. And then I think it's explainable. You provide simple, concrete activity that a client can do, such as puzzles, word games. The client can focus their attention more on. You have to, constantly reorient your client, and then you help the client to, establish what the reality is and what is not unreal. You need to stay with the client if the client is frightened. Okay, if there's any form of anxiety. Remember, we said when anxiety is increasing, it mostly means that the client's hallucinations or whatever they are experiencing is mostly increasing. So when there is any form of a situation that frightens the client, you need to stay with the client. You speak in simple, direct, and concise manner with your clients. You need to reassure the clients and then ensure that there's safety in the client environment. You remove the client from what we call a group therapy, especially if the client's behavior is too bizarre, disturbing, and dangerous to others. This is why I was saying that if you notice that a client is experiencing certain form of bizarre behavior, you don't leave the client in the midst of a group. You need to ensure safety by moving the client out. And then you need to set realistic goal for the client to achieve. Initially, you do not have to give the client the opportunity to make choices. You need to make the choices for the clients. And then as time goes on, as the client's condition improves, you let the client make decisions that you think the clients can make this time on. We said environmental stimuli need to be decreased as much as possible. You monitor for suicidal thoughts or ideations. Then you need to also bring in other means of therapy. So you need to use alternate means of expressing feelings, such as through music, art therapy, or writing. If it is true that the clients can use to express their feelings, you have to allow them. Then for clients with hallucinations, safety is mostly the priority. So ensure that the clients do not have an auditory command telling the client to harm others or self. So safety is mostly a priority when it comes to hallucination. So I specifically had this on what we call client having active hallucination. And I think this one was more on command hallucination or hearing. Okay, this one was more visual hallucination. So a client experiencing visual hallucination, like more a case study thing, what do? You need to monitor what the hallucination in terms of the cue. What is the client seeing or what is the client hearing? Okay, then you assess the content. Assessing content means that you ask the client, what is the voices telling the client to do? Are they telling the client to harm someone, or is the client seeing people with guns around? So you need to assess the content of the hallucination. We said a one-on-one interaction with your clients. So intervene with one-on-one contact. You decrease stimuli in client environment. We've talked about it. Avoid, conveying to the client that others are also experiencing the hallucination. So that is where you need to present the reality to the client. Let the client understand that he alone is seeing or hearing those voices. But you, the nurse, you are not seeing or hearing those voices. So don't try to say that other people are also hearing it. That will, make the client to continue to believe that, yes, those things are still there. or they are actually seeing things or hearing things. You need to, respond verbally to anything real that a client talks about. That is why we said that you need to validate to see which part of, the client's situation is actually real. Then avoid touching clients, encourage the client to express what we call their feelings. Then during hallucination, attempt to engage the clients through other activities I talked about, like gaming, puzzles, and all that. You do not have to accept and do not joke with the client in terms of the client's behavior. So if the client is telling you that I'm hearing certain things, don't joke with it. Take it for serious and act accordingly. And then don't also judge the client's behavior. Provide activities that the client can easily do. You monitor for signs of increasing anxiety or agitation, which we said that mostly indicate that the client's hallucinations are increasing. Stimuli need to be decreased. Your medication to assist the client as well. So this would be the last thing for someone with delusions. I think I even did delusions, right? I talked about delusions, and I said that in delusions, you need to, tell them that, yes, they are thinking that people are wanting to harm them, or they think they are the boss, but in reality, interact based on reality with them, encourage them to express what we call their feelings. You do not dispute what a client is telling you, okay? So do not dispute the client or try to convince the client that what they are, feeling is false, and then initiate your one-on-one activity with them. You might need to alter your hospital routines in order to see the client's condition. You need to, give some positive feedback to the client if the client is able to accomplish certain activity. And that brings us to an end to what we call schizophrenia and hallucination, delusions, and all those things we'll talk about for today. Before we use a few time, or we use about 10 minutes to 15 to do certain questions, and then we will drop it there. But before that, if you are here and you have an input you want to make, you can bring it up before we move on. Okay, so this is a question that claims a client on the psychiatric unit has been diagnosed with schizophrenia. He begins to tell the nurse about how the CIA is looking for him and will kill him if they find him. Which of the following is the most appropriate response by the nurse? A is that we have A, and that is ridiculous. That is a statement from the nurse that is ridiculous, Clint. No one is going to harm you. B, the CIA isn't interested in people like you, Clint. C, why do you think the CIA want to kill you? D, I know you believe that, Clint, but it's really hard for me to believe. Who are going for C? Who are going for D? So C and D's. Defend your answer. Let's go.
Hello.
Yeah, hello.
Yes, I'm going for D.
Why going for D?
Yeah, they said that I know you believe that. That is clean, but it's really hard for me to believe. That means that the nurse is actually acknowledging the fact that the client is like thinking about something, but then that is not real. And then C is out just because of why. The why question: why do you think the CIA want to kill you? So that one is out. And then the CIA isn't interested in people like you. This is not therapeutic. This can even make the client even more angrier.
Okay.
Just same as that's ridiculous. So for the FMP, I get it's they're almost the same.
Okay. Okay. All right. All right.
Yeah,
That's
boss.
fine. Yes, hello.
Yeah, I go in for D in a sense that the answer validates the patient's feeling and goes along to let him know the reality behind. That is why I go in for D. Thank you.
All right. Is that Paul? You also want to come in? That Henrietta
Yeah,
will do that.
boss,
Yes.
I'll go
Yes.
for
Go.
the D. C is
Okay.
already C. I'll go for D. C is already out because of the Y, and the B is like the nurse is even insulting the client, and the A, that is ridiculous. It's like you are rejecting what the people, what the patient is saying. So the only
Telling you.
option that is good is the D.
Okay. All right. Thank you. Madam Henrietta, you want to come in? So conclude for us, then we move on.
Okay, I'm going for C. This is because why do you think the CIA wants to kill you? From what you touched right now, you said we should try to understand what the patient is going through. We have to ask questions about the hallucination so that we know how to solve it. So asking that question is not disputing anything. It's actually trying to help us know what is really happening, what our patient is really saying.
Okay.
But
All right.
you say, it's hard for me to believe, meaning you are not siding with what he's saying. But the truth is, it's actually not there. So it's not something you can actually believe.
Okay.
Not
Right.
believing it. He's actually seeing it.
Okay. All right.
Talk
Your point
about
is well made. Okay, that's fine.
Yeah.
But but I believe therapeutic communication, we're all here. The use of why, like they said, makes the C to be wrong. Okay. The use of the word why there. The use of why is making the entire number C to be wrong. Okay, so let's take notes that don't go for why. I said this from the beginning of our class. Or when I started mental health, that we don't use why in replying people, like why statements are always wrong. Now the D, just like they said, those who went for D, the D is actually acknowledging the client's feeling. That I know you believe that. You are acknowledging the client's feeling. And then you go ahead to present the reality. But it's really hard for me to believe. It's not like you are disputing the client's feeling or what the client is saying. You have acknowledged the fact that the client is having a certain feeling and have gone ahead to present the reality. The reality is that what the client is thinking of is not true. So you do not believe that, which is actually the reality. Okay. In fact, why statement, just cancel them out first before you even make your answer selections when it comes to mental health. It is the why that makes the C to be wrong in the first place. Yes, there's another handout. Yeah, it's
Okay, so just going back to why I picked why was to assess the patient's thought process. But since we can't use why, how then can we assess as in kind of
you
ask
are,
the
you are
patient?
thinking, you're not thinking into the question. I don't want to go to that direction. You are not thinking into the question. Understand that why statements are always wrong. I don't want to. When you do that, you are now thinking into the question. Yes, Mr. Paul. Probably Mr. Paul can help us. Mr. Paul, your hand is up again.
So to my sister, English is saying that whenever you begin an option, when an option begins with Y, it's judgmental, like you are inducing anger. So don't even go there. It's a fifth word.
Okay,
That's what
sure.
English is saying.
It's a straightforward thing. In mental health, don't go there. If it is why, take it. Don't go there. Don't ask yourself, questions about that option. Just cancel it out. That's all I can say.
Okay, thank you.
Yeah. All right. Parents ask a nurse how they should reply when their child diagnosed with paranoid schizophrenia tells them that voices command him to harm others. Which is the appropriateness in reply? A, tell him to stop discussing the voice. B, ignore what he's saying whilst attempting to discover the underlying cause. C, focus on the feelings generated by the hallucination and present reality. D, present objective evidence that the voices are not real. Yes, Madam Mary.
Okay, thank you very much. Tell him to stop discussing the voices. This one is not therapeutic. B, ignore what he's saying while attempting to discover the underlying cause. No, it's no also
Where is it?
appropriate. I'll go for C. Focus on the feelings
Where is it?
generated by the hallucinations and present reality.
That
So
place
let's say
I can't
somebody is trying
reach
to
there.
harm.
Swallow the water. Swallow the
Please,
water.
let me mute here, Madam. Okay, go
Okay.
ahead. Yeah.
Let's say somebody is trying to kill somebody. You have to think of safety first before you now present reality. You won't say that it's not true, it's not true. What if the things it's really the voices are really coming? He tries to pick something to harm somebody, then you would have been wrong. So my answer is C. Then the D say present objective evidence that the voices are not real. No. So C is more appropriate according
Okay.
to me. Thank you.
All right. Yes, that's what the question says. More appropriate. Okay, more appropriate. I think we all agree with Madam, right? All agree with Madam Mary that the most appropriate answer here is a C, where you need to says that you focus on the feelings generated by the hallucination and then present what the reality is to them. That is the most appropriate response here. So the option B, when you look at the option D, it's more like trying to force the client to believe what the reality is, like you are persuading the client. So present objective evidence that the voices are not real. It's more like you are forcing the client. Remember, we said we don't force them. Just present them. Just tell them what the actual reality is or what the truth is, and then you take it from there. This question is also very straightforward, and I believe everyone here can answer this. That Tony, age 21, has been diagnosed with schizophrenia. He has been socially isolated and hearing voices telling him to kill his parents. He has been admitted to the psychiatric unit from the emergency department. What is the initial nursing intervention for Tony? A is to give an injection of thorazine. B is to ensure a safe environment for him and others. C is to place him in a restraint. D is to order him a nutritious diet. So this one too is very straightforward. Nobody here, I believe, will get this question and then we'll be thinking more about well, let's see if you have if you have maybe someone has a contrary answer to what others are choosing. So people are going for B, right? I think this one, safety first. And as we will say, the exam we are preparing to go and write is a safety exam. And it's a safety exam. So safety first. Options that ensure safety or interventions that ensure safety is what we probably will go for. And then before any other thing. So B is the most appropriate answer here. Let's see, look at something else. Clint, a client on the psychiatric unit has been diagnosed with schizophrenia. he begins to tell the nurse about how the CI is looking for him and will kill him if they find him. A client's belief is an example of which of the following: A. Delusions of persecution. B. Delusions of reference. C. Delusions of control or influence. D. Delusions of grandiose or grandeur. Yeah, Mary can come in.
Thank you. I think it's delusions of persecution. That one is a delusion that refers to somebody thinking that another person is trying to harm him or her. What's that of the reference? You are just trying to make a reference to something, but it's not something that will harm the client.
Okay.
So the answer is A.
Okay.
Thank you.
All right. She says that the answer is A. And then she thinks that A is the best to explain client's behavior at this point, which is, yes, persecution. You having a thought or the thinking that someone is planning, or certain group of people are planning to harm you or attack you or single you out and cause harm to you. So this time, CIA is after Clint. That is what Clint thinks. So that is persecution. Then we have another one on the nurse is interviewing a client on the psychiatric unit. The client tilts his head to the side, stops talking in mid-sentence, and listen intently. The nurse recognized from these signs that the client is likely experiencing which of the following: somatic delusions, B. catatonic stupor, C. auditory hallucination, D. pseudo-Parkinsonism. Which kind of which of these thoughts is the client having at the moment? Is it somatic? Is it catatonic? Is it auditory hallucination? Is it pseudo-Parkinsonism? Yeah, Carol.
So this one,
yeah, go ahead.
personally, I'll go for B, catatonic stupor.
Okay.
Looking at the options available, because it's not somatic. It's not somatic. Neither is it auditory hallucination. I don't know of the pseudo-Parkinsonism. I have no idea about what word it is. I'm not sure you mentioned it also. But from what I'm seeing, analyzing, I want to go for catatonic stupor, because stupor means being in a fixed or a stuck position. So that's what I think.
Okay. So, I mean, catatonic stupor is more like WASI flexibility, okay, maintaining a certain posture. But let's see if someone has different things to tell us. Okay. Madam Mary, your hand is also up.
Okay, thank you very much. And the same thing, I'm going for the B, catatonic stupor. You know, the pseudo Parkinsonism is like trying to exhibit the signs and symptoms of a Parkinson.
Yeah, mostly side effects of medication.
Client. Those, but this client is not doing that. Then the auditory hallucinations, the client will what? Hearing voices. I don't think that's what they also said. So it's the catatonic is like trying to copy somebody's way of a posture or something.
Okay.
So
Right.
I'm going for that one. Thank you.
That's fine. I want the last contribution. Who still wants to tell us something? All right. See, it is not catatonic stupor. This person is exhibiting typical auditory hallucinations. This is how the auditory hallucinations behave. Now, you are talking with the client. You are having, see, the catatonic stupor is just like WASI flexibility when the client has to maintain the posture, a certain posture, assume a certain posture for long hours. This is you are having a conversation with the client. You are talking to the client. Then the client sits down, turns the head just imagine, turns the head as if someone is talking to her. I don't know whether you are trying to imitate, just like I'm saying. Then the person turns the head and then now becomes a little bit, the client was talking, but stop talking in the mid-sentence and then listen intently. Meaning that's like someone is communicating with him or her at that moment, which is typical of auditory hallucination. So I presented this in another class, and they all went for what we call catatonic. Okay. They all went for catatonic. And I was saying that it's not catatonic, it is typical of auditory hallucination. The person is talking, all of a sudden stops talking and then tilts the head to the side. It's like something, client is now listening to something. So this is typical of auditory hallucination. When you meet this question or this example anywhere, don't miss it. This is typical of auditory hallucination. You can read the question again. The client tilts his head to the side and stop talking in the mid-sentence and listens intently. That is a description of like someone talking to you and you trying to listen attentively to what the person is telling you. And that is an indication of what we call, auditory hallucination for these very clients, not catatonic. The catatonic, like I said, you maintain a certain part of your body in a certain posture. It could be like you stand quietly. And even that one, the client has to maintain that position for hours. You need those kind of things to describe the question. Yes, let's hands up there. Yes, Mr. Richmond.
Yeah, okay. I personally choose the C. With a catatonic stupu, it's more or less a depressive state
Okay.
and schizophrenia,
Okay.
because it has some two phases, excitement phase and then catatonic stupu. So the catatonic stupu is more or less depression. So the auditory hallucination is the right answer. That is why I choose the C.
All right. People are already leaving us saying we're so close. I think we're about 20 minutes into our class. Of course, I do not start early and do whatever I wanted to do today. Let's do this last one and drop it then. The nurse is interviewing a client on the psychiatric unit. The client tilts his head to the side, stop talking in the mid-sentence, and listen intently. The nurse recognizes behavior as a symptoms of the client's illness. What is the most appropriate nursing intervention for this symptom? So the follow-up, this is like a case study question. Okay, and we know that this is how the case study questions they prefer with. They'll give you the main question, give you the first question, then follow-up question will also come. So based on what we know, we've now established the fact that this is typical of auditory hallucination. What interventions are you going to give for this? A is that ask the client to describe his physical symptoms. B, ask the client to describe what he is hearing. C is administer a dose of benztropine, and D is to call the physician. Call physician for additional orders. Yes. There's a hand up, Madam Carol. Is it an old one or a new one? I think you had a call. It's from here. Yes, yeah. So I think I'm having the answers there. All right. People are going for B, right? So this time around, we know that it is auditory hallucinations, and we said that in auditory hallucinations, you need to question the client to know more about them. What the client is thinking about, the client's hallucination. What are they about? Okay. I think we can end it here for today. And then tomorrow, God willing, when we meet, we'll do the personality disorders and then probably go into other areas. We'll gradually be bringing it to an end. That will be that for today. So thank you for coming. All right. So I want us to start with personality disorders. Let's, like I said, we look at the various clusters. Then each cluster has some types or examples of the personality disorder. So we look into the clusters, and then each cluster, and then how to also manage or interventions for patients exhibiting certain personality disorders. So, as we all know, personality disorders has to do with an individual expressing certain form of maladaptive behavior or traits that may affect the individual's functioning and then relationship with people. And so, example of a personality disorder that I mostly use an example is antisocial. So, okay, and we've always been with people who are antisocial, and these people are mostly, we say, they are stubborn. They don't want to stick to rules. When you tell an antisocial or an antisocial personality disorder person that, or someone with such a personality disorder, to stay here, these are the rules and regulation regarding this institution, the person will find a way to beat that and always have issues with rules and regulation. When you take someone like a dependent personality disorder, these people find it very difficult to make choices for themselves or decisions. And so they have that, low self-esteem or that kind of low confidence in making choices. So they always depend on people to survive or in terms of making decisions. So we'll go into each of them and then we'll look at what characterize them. So we'll look at the various characteristics of each of the disorder. So mostly affects the way the person relates with people and then also impairs functioning. They show maladaptive behaviors. The people or the client usually remains in touch with reality and typically has a significant lack of insight in self-identity and then interpersonal behaviors. That's empathy and intimacy. So when it comes to reality, these people mostly remain in touch with it. They actually, have insight to, most of the things or the reality in terms of reality-based things. They really remain in touch with it. But when it comes to self-identity and some interpersonal behaviors, that's where sometimes they lack some insight into it. Mostly stress. We know that stress is one of the things that mostly brings about some of these things. When the person gets stressed, that person starts misbehaving or starts showing this kind of disorders. So stress mostly exacerbates what we call manifestation of personality disorders. Mostly it is not related with what we call substance abuse or misuse or general medical conditions such as head injury. And so before you diagnose someone of having a personality disorder, first of all, look at the person. Or you need to rule out any kind of an underlying medical condition that could cause the person to behave the way the person is behaving. We know that, I believe we've all heard that people could get certain form of head injuries that will make them to behave abnormally, right? We've all heard that before, or might have seen people having or getting head injury to a certain degree, to the extent that it can affect their way of thinking and they start to exhibit some certain form of unwanted behaviors. The same thing, people takes certain form of drugs or abuses alcohol, could be weed, it could be heroin, cocaine, or whatever, and they start to misbehave or start to show certain form of behaviors. Now, before you diagnose the person of having a personality disorder, you need to rule out all these things so that you find out, is it the drug that the person abused that is what is causing his problem or her problem, or is it the accident or the RTA or the head injury the person had that is causing the person to behave in that way? So you need to rule that one out before you start, because personality disorders are not mostly directly related or associated with this kind of things. So you need to rule out these things before you finally conclude that, okay, the person hasn't engaged in any drugs, neither has the person had any form of medical condition that could lead to that before you conclude that it is a personality, disorder. So just like I said, when it comes to personality disorder, we have the classes or clusters. They have been grouped into various clusters, and each cluster has, the disorders or the types or the examples, if you want to put it down. So when you take cluster A, personality disorders, cluster A, personality disorders, types include, more odd disorders like schizoid personality or schizoid personality disorder, schizotypal, and then paranoid. Among the three, I think the most common one we come across it is paranoia, people who are paranoid. Okay. So now let's go into each. So when you take cluster A has three types. That is schizoid, schizotypal, and then paranoia or paranoid personality disorder. Now, let's go into the first one, that is schizotypal personality disorder. This is mostly characterized by an inability to form warm, close social relationships. So these people are mostly reserved. Okay, they have that kind of, reserved personality. They are mostly reserved. They are not able to maintain what we call social or close social relationship. So some characteristics of them is that they have social detachment and lack of close relationship. That is for the schizoid personality disorder. They lack that kind of close relationship with people, or they are not able to maintain close relationship and social detachment, where people have gathered, or a lot of people have gathered. This type of people, or people with this kind of personality disorders, do not want to go in the midst of a group of people just like that. Then they have what we call interest in solitary activity. So solitary activity is where the individual does things alone. Okay, does things alone. Just like when we are learning about headaches and we are looking at the various type of play, we have solitary play. And so solitary play where the child wants to play alone. Okay. And so these people, they have interest in what you call solitary activity. A person wants to be alone and then be doing his or her activities. They have aloofness and then indifferences, restricted expression of emotions. So they have that kind of they are not able to even express their emotions for people to see, because they are not able to go to people, or they don't associate themselves much with people. So how would they be able to express their emotions for people to know that, okay, this is how this fellow is feeling? So they have what is called restricted expression of emotions, and then lack of interest in what we call others. They don't want to have anything to do with people. They always want to be alone, always want to be alone, reserved kind of people. Okay, so that is what we call the schizoid personality disorders. This is what characterizes them. They are more reserved people. Then we have the schizotypal. So the schizotypal personality disorders is characterized by display of abnormal or highly unusual thoughts, perceptions, speech, and behavioral patterns. Now, they are more suspiciousness. They behave just like how the paranoid people will behave. So they have certain traits of paranoid behavior where they are mostly suspicious. They are unable to understand how their behavior impacts on others. Okay, these people mostly do not understand how their abnormal behaviors impacts or affects what we call other people as well. Then they also have what we call, eccentricity. When it comes to the meaning of eccentricity, I want to get it for you. The last time, where is this thing? Let me come. Yes, yeah, yeah. So when it comes to eccentricity, they have what we call, the innovative thinking, artistic expression, outside the box problem solving. Okay, so that is mostly how they have that certain form of odd behaviors. Okay, they have magical thinking. That is what the D is saying, magical thinking. The way they think, okay, they think in a certain way that not all people kind of think in that way. So they have that kind of magical thinking, and then more of like out of box problem solving. Maybe there is an issue. There is a straightforward way of solving the issue, but these people will try to go outside the box before they come to the main point in solving the problem. So they have that kind of magical thinking, and then odd thinking as well as speech. So it all explains what we call the eccentricity. Then, they have a certain form of relationship effects. They have some form of blunt affect as well as repulsiveness. So these people, their way of thinking, that's why I say unusual, highly unusual thoughts. Okay, the way they think, it's much more odd when you compare it with people. Okay, if the thing is to go straight forward, they have some magical way of thinking about it and solving the problem. Okay, and that is what the schizotypals, personality disorder, that is how they behave. The way they think, it's more odd, it's unusual, highly unusual than other people. Even though they can do the thing, they can solve the problem, but they will do it in kind of curious or sorry for that. So they do the thing in more, odd way, okay, the way they think, and then unusual as well too. Then among the cluster A, the paranoids are there, the paranoias. And so we know the paranoias, that these people are more suspicious. They have trust issues. So when you are dealing with someone with a paranoid behavior, one thing you have to be mindful of is that you need to be honest and truthful. If you can't do the thing, don't say that you can do it. So paranoid personality disorder is mostly characterized by suspiciousness and mistrust of others. That is paranoia. They are, characteristically, they are suspicious, distracting, distrusting, and then argumentative. They may be hostile because they don't trust people or they don't have trust. They may be very rigid, very difficult to deal with them. Critical and then controlling of others. They also want to kind of control people. And then they may also have some certain form of grandiosity where they mostly think like they are most powerful, they are most important people among you. You are talking to them and they think that they are the most important people. Now, when it comes to people with paranoid behavior, one thing that we all need to understand is that we have to be very careful when they are in our midst, or we are talking to people, someone who you are talking to someone and then you have a paranoia patient among you. One thing you have to do is that you need not to whisper, okay, or laugh in front of them, because they may misinterpret your laughter to be that they are the ones that you are laughing at. Or when it comes to the whispering, when you whisper into someone, the person might pick that act as you are trying to harm, okay, or you are kind of, plotting against him or her. So do not whisper or laugh in front of a client with paranoid personality disorder, because the client will think that you are talking about or laughing at them. This increases the paranoia or their suspiciousness, so on their mistrust. So that is one take home that I want us all to take note of. When we get a question on paranoia, personality disorder, and you have an option like you can whisper and you can laugh in front of them, you have to be very careful with that, because they may misinterpret that to be that, whatever action you are doing is towards them, and that may, increase their paranoid behavior. Now, among these clusters, like I said, the most common one is what we call, paranoia. So let's look at how to manage someone with a paranoid personality behavior. So interventions for paranoid personality behavior. Safety is an example of safety. So safety first. So you need to make sure that you provide a safe environment for your client. You need to assess the clients that they will be, or you need to assure them that they are safe. No one is plotting to harm them, or no one is plotting to harm them. Yes, no one is thinking that probably they want to do them something. So you need to assure them of their safety. Then you need to assess for what we call suicidal thoughts and risks. Then you need to diminish what we call suspicious behavior, such as whispering. That's why we said that you don't need to whisper in front of them, okay? Or you don't need to laugh or do anything that they may become more suspicious. Then you need to remain calm, non-threatening as well as non-judgmental when you are with them. You need to engage the client during brief but frequent interaction. So these people, because of their suspiciousness, you have to be very brief with them when you are interacting. And then you need to also, your interaction with them should be much more frequent. Don't waste too much time trying to talk with them, okay? Or, when you are interacting with them, you need to be very brief, but rather more frequent interaction with them. And then trusting relationship is the key here. You need to establish trust because these people mostly have trust issues. So maintain trust, a trusting relationship. Then you maintain physical boundaries, avoid crowding what you call the client. So you need to set physical boundaries because of the fact that they are more suspicious. They have that trust, lack of trust for others. And then they easily become distracted. In that instant, you might need to set boundaries with your client. And then you also have to promote what you call increased self-esteem with them as well. Okay. Engage them in certain activities that may help them to increase their self-esteem and confidence. So that is on paranoid or paranoid people. And then cluster A personality disorder. There's 3 types. So we have schizoid, we have schizotypal, and we have paranoia personality or paranoid personality disorder. You need to also respond to them honestly. So you need to be honest with them when you are talking with them. You follow through with your commitment made to your client. So if you tell your client that I will be with you in an hour time, you need to fulfill that. You need to make sure that in an hour time you are with your client. If you don't fulfill that kind of promise or commitment you've made to your client, the client will start developing that kind of mistrust with you. And that can bring about what we call the paranoid behavior. You need to acknowledge their feelings, but tell the client that you do not share their interpretation of an event. That's where you need to present them with what we call the reality. Acknowledge their feelings, allow clients to express themselves, and then present what the actual problem is to them or what the actual reality is to them. You have to provide a daily schedule of activity, then assist them to also identify certain form of directional activity like games, puzzles, where they can concentrate their attention much on. And then you need to gradually introduce them to group therapy. Initially, you might have to engage them one-on-one before you later move them into group therapies. You need to focus conversation on reality-based topics. That's where you need to acknowledge the client's feeling. Then you present to the client what the reality is. So reality-based topic discussions are very, very important. You need to use role playing to help the client identify thoughts and feeling. You provide positive reinforcement for success. If the client is able to do something, you need to praise the client. You need to let the client know that they have been able to achieve certain form of success so that you kind of motivate the client to do more. You do not have to argue with their delusions. These people also have delusional thoughts, okay? So always don't argue with their delusional thoughts. I mean, accept it, present the reality to them, and that they think that way, but in reality, that is not what it is. You do not have to whisper in their presence. We have talked about that. Then you provide opportunity for client to complete small tasks that they can do. That is where you need to engage the client in certain form of activities. So those that the clients can do, while other clients to engage in. Then you monitor their, I mean, physiological needs. That is diet, drinking, sleeping, and then elimination patterns. You need to make sure that you are meeting all these things. So that is meeting their physiological needs is also important. Then you monitor for agitation, decrease any form of stimuli within the client's immediate environment as needed. That is on how to, manage or intervene in terms of your intervention for someone with paranoid personality disorder. So we are done with cluster A.
Oh my goodness.
The various types, or the various types that falls under cluster A personality disorder. Then we go into what we call the cluster B. The cluster B's kindly mute out for us. We are getting some feedback. Someone is muted. Kindly mute out for us. Under cluster B, we have histrionic, we have narcissistic, antisocial, and borderline. So these people have, under cluster B, we have, I think, 4 types. That is histrionic, narcissistic, antisocial, and borderline. The cluster B, they are mostly dramatic. They have that dramatic kind of behavior. They are more emotional and then erratic behavior. So the erratic, if you think of the antisocial people, okay, always be misbehaving. If you tell them not to go here, that is where the person will go. These are the rules. The person will always find a way to beat what the rules are. Now let's go into them one after the other. So histrionic personality disorder. And these people are overly dramatic and intensely expressive behavior. So they always want to be like the center of attraction or the center of attention. If you want to understand histrionic personality disorder, think that these people always want attention on them. So the way they dress, the way, they behave, they are always drawing attention towards themselves. So they have that kind of overly dramatic, intensely expressive behavior. The person has still not muted that. City. Manchester City. You have not muted that. So histrionics are more dramatic. They always want to be the center of attention. So they are lively and dramatic and then enjoy being the center of attention. Has poor and shallow interpersonal relationships. Okay, so they have that form of, shallow and then a poor interpersonal relationship. That's in their relationship with others, mostly it's more of shallow behavior. And they are mostly sexually sedative and, provocative. And that is where they always want to, they are center of attraction. So they dress in a way that will sexually provoke people or sexually seduce others, okay, so that people will always be attracted to them. So they may be sexually sedative or provocative. They dramatize personal life and may appear theoretical. So these people mostly dramatize things. If the thing is just something small, the person will kind of dramatize it so that you pay much attention to that person. So always wants attention on yourself. They are overly concerned with appearance. Okay. It is the appearance that mostly attracts people. It is the appearance that will make you turn and look at the person. So that is how they are mostly concerned about what we call their dressing or their appearance, so that they will draw what we call, or they will tend to become what we call the center of attention. They easily get bored. Okay. So that is on what we call histrionics. So histrionics, just understand that these people mostly want to be the center of attention. They always want to dress in a certain way that people will be looking at them or people will be paying much attention to them. Okay, they are mostly sexually seductive or provocative. They have poor, shallow interpersonal relationship. Then we have narcissistics. Narcissistic personality disorder is also characterized by increased sense of self-importance. And then they are, a preoccupation with fantasies and then unlimited successes. So they always want to, they always want to show that they are the most important, kind of have some certain form of, grandiose kind of personality, or grandiose behavior. Okay. So they always want to be, or they have that increased sense of self-importance. They have a fragile self-esteem, the need for admiration, and an inflation of accomplishment. They always want you to hype them, that kind of hyping kind of behavior. Okay. And then overestimation of abilities, and then they also underestimate the contribution of others. So if they are in a group or you are working with them in a group, they always want you to take, their suggestions. They don't want, they overlook other people's contribution. Okay. So, and then overestimation of ability, something that they cannot do, they will tell you that we can do. Okay. Give it to them, and by the time you realize they have done the thing anyhow from you. So they overestimate their abilities, and then they also underestimate other people's, in terms of abilities and contributions. They have that kind of lack of empathy, and then sensitivity to the needs of others. So that is where they want to look down on people and all that. They always want to be that they are the most important among the group that they are working with. And so that is what the narcissistics, in terms of behavior, that is what characterizes them. And then we have the antisocial. So the antisocials are also there. That's the most common example or type I've always been talking about. Their behavior is more like, they are more selfishness. An ability to maintain, an inability to maintain lasting relationship with people. They have poor sexual adjustments, failure to accept social norms. So that is why I was saying that they have issues with rules and regulations. Okay. They always want to do the wrong thing. And then a tendency towards irritability and then aggressiveness. They are more, aggressive as well, very irritable. Perceive the world as a hostile environment. So they always perceive the world to be very hostile. That is why they mostly exhibit that behavior of not wanting to, adhere to rules and regulation or conform to social rules. They have lack of empathy or feeling of remorse. When they are wrong, they don't want to accept that they are wrong. Then they are egocentrics, or the egocentrism, that is focus on personal gratification. They always want to do things that satisfy them. Okay, they don't want to they don't think other people's feeling, or they don't have feeling for other people. They always want to do things that satisfy them, and they are okay to focus on personal gratification. They have that manipulative kind of behavior. So manipulative, and then deceitful. So they always want to deceive people, and then manipulative in order to find their way out. They are mostly irresponsible, impulsive, and engage in risk-taking, behaviors. The person has one CD left that the person has to use it to buy food. The person is hungry, but want to go and use it to play what is the name? Play belts or something like that they can easily lose their money. Okay. So they like taking risks. So they engage in risk-taking behaviors. And then, persistent or frequent feeling of anger, refusal to conform to social rules, and then normative behavior. And so these are also what characterize people with antisocial personality disorder. Then the last type under cluster B is the borderline personality disorder, which is mostly characterized by instability in interpersonal relationship, unstable mood, and then self-image. They also have impulsiveness and then unpredictable behavior. And who is writing on my screen? So these people have what we call poor self-regard and then unstable self-image. So I mean, borderlines, they kind of more look down more on themselves. Okay, so they look down on their self more. Okay, so they have that poor self-regard and then unstable self-image, unstable and intense personal relationship, and then lack of empathy towards the needs and the feeling of others. They mostly have extreme shift in mood. They are mostly impulsive. So that is also some of the few characteristics or some of the behaviors that people with borderline will show for you to know that this person is exhibiting a borderline. So they mostly have that kind of, look down on themselves more kind of poor self-regard, unstable self-image. They also have self-damaging behaviors, okay, such as cutting. And those behaviors are also kind of to draw attention. Okay, so self-damaging behaviors such as cutting. So they mostly want to cut themselves, like self-damaging. They engage in risk-taking behaviors. They are also argumentative and then hostile in response to perceived slights or insults. So, and then they are also manipulative, intense feeling of anxiety in response to stress. So whenever they engage in any form or they encounter any form of stress, they become more anxious. They have chronic feelings of emptiness and intense fear of being rejected. So that's why I was saying that they mostly do, down on themselves. They think like, they don't have that ability to do something. And so they have intense fear of being rejected. If they do the thing and they fail, people reject them. So in that manner, they wouldn't want to do it at all. They have a splitting behavior. So splitting behavior is where they tend to come in between people and then destroy their relationship. Let's say I am friends with someone, then the person with that borderline personality disorder will always want to come in between the two of us and destroy our relationship. So that is splitting behavior. See others as all good or bad. Create conflicts between individuals by playing one person against the other. So you will always want to split, people's, they see that you are friends with someone, you have very good relationship with the person. By the time you realize the person has gone to do you bad to the other person, and then it will create that kind of conflict between the two of you, and then that kind of relationship that you guys used to have will end there. So they have that splitting, behavior. That is also what we call borderline personality disorder. And that brings us to the end on cluster B. Then we'll move on to cluster C. When we finish, we'll talk about general interventions for personality disorder. So it will fuse into all that we've talked about. And so the last cluster is cluster C. And cluster C talks about people who are more anxious, fearful type of people. And so examples are the OCDs, or obsessive compulsive personality. So we talked about OCD when we're looking at the anxiety behaviors. So the last time I remember someone asked, is OCD a personality disorder or an anxiety disorder? So you can treat OCD and anxiety just like I said, because anxiousness, or when they are more anxious, they start to exhibit those obsessive and compulsive behaviors. And then we have the avoidant people, and we have the dependent. So we have OCD, that's obsessive compulsive personality disorder, avoidant personality disorder, and then dependent personality disorder. These are the three types that falls under cluster C. We already know obsessive compulsive personality disorders, that these people are mostly preoccupied with certain ritualistic activity. And then they have certain form of, obsessiveness. If it's about being clean or neatness, they always want to be neat. The moment, you enter their room and you try to jam things up, you start having issues with them. Okay, so that is the obsessiveness. Compulsiveness is where they are more of the ritualistic thing, always engaged in washing hands or doing certain things. When they are more anxious, okay, or engaging in ritual activities or behavior. So obsessive compulsive personality disorder is mostly characterized by difficulty in expressing warm and tender emotions. They are perfectionists or perfectionism. So that is where they always want things to be in order. Obsessiveness. They always want the remote to be on the center table. If you make a mistake, you pick the remote from there and drop it somewhere else. You have issue with that person. They are mostly stubbornness. They're also stubborn, and then they need to control others, and then devotion to work. So they always want to do something, engage in certain activity. These people are perfectionists with unreasonable high expectation of self, and then they have inflexible and then preoccupied with details and rules. So if the thing is A, they always want everybody to go the A way. Don't try to maneuver yourself, or don't try to beat around the bush. If the rule says this, they always want you to go according to what the rule says. And then they have sense of self-driven, primary from work, social and personal relationship view as secondary to work and then productivity. They have what we call difficulty with understanding the ideas, feeling, and behavior of others. They engage in rituals. So these are what obsessive people do, or the obsessive compulsive personality disorders. This is what characterizes them. They are mostly, more paying attention to details, paying attention to ritual activities. Okay. Then we have, avoidance personality disorder. These people have what we call social withdrawal, extreme sensitivity to potential rejection. And so if they always think like they will be rejected, social withdrawal is there. The name goes avoidant. They always want to avoid something. Okay, so feeling of inadequacy, hypersensitive to reaction of others, and poor reaction to criticisms. They always want to avoid criticisms, and so they don't want to even engage in the thing, because when they engage and they fail and you criticize them, they don't want to do the thing again. And then they have what we call social isolation. They also exhibit that social isolation behavior. Lack of, support was also there. So lack of support system. It's also another, they mostly don't want to engage in anything, more reserved, avoidant, always avoiding things, social withdrawal. Okay. The last one is dependent. So dependent, they always want to depend on other people for, choices, making decisions. So these people are characterized by an intense lack of self-confidence, low self-esteem, and inability to perform or function independently, such that individuals passively allow others to make choices for them or make decisions for them. They, and assume responsibility for major areas in the person's life. Now, you are with this person, the person fears to make decision. Whatever it is, the person has to call. So if you are here and you are the type that whatever, even if it's water that you want to go and buy, or water that you want to go and buy, let's say you want to go and buy water, a bottle of water, you have Vena there, you have Belaqua, you have Baltic, and you always want to call someone to choose for you which one to buy. It means that you are kind of exhibiting dependent personality, okay, personality disorder. At least you should also have the confidence to be able to make choices on your own. And I think this is also common among us. We all have colleagues that if they want to do something, they always want you to decide for them, or they always want to, it's not like they always want to hear, your contribution or whatever you have to say, but they always want you to make that choices for them. Okay. We all have such kind of people in our life that, so that is dependent personality disorder. They always want you to make the choices and decisions for them. The dependent client has a great difficulty in making what we call choices. So that is on what we call dependent personality disorder. And the last type under what we call cluster C, personality disorder. Then we move into the general interventions for a client with what we call a personality disorder. This has, safety is first. Safety is important here. So maintain your safety against certain form of destructive behaviors. Those kind of destructive behaviors like those with manipulative behavior like antisocials and those things. You might need to maintain safety, and then ensure the client ensure that the healthcare team is consistent with information and response to the client's acting out behavior. So these people, if you are caring for them, you need to be very consistent with them. And then when the client is behaving abnormally, you have to respond to that. Then make sure the client is doing the right thing. You need to allow clients to make decisions and be independent, especially for avoidant people and then, or dependent personality disorders. You need to help them to make choices and then allow them to make decisions independently as well. You have to encourage the client to discuss their feeling rather than acting them out. Encourage the client to also keep a journal to record their daily feelings. How they felt throughout the day. They will have to keep a record of it so that, when you come, they can show it to you that today this is how I behave, or this and this is what happened to me. But then you have to discuss expectation and responsibility with your clients, discuss the consequences of their actions, and then yes, to you, or the consequences of their behavior. You need to let them understand. Inform the clients that harm to self and others, as well as properties, are not acceptable. So you need to let the clients know that as well. Develop a written safety contract with your clients. So make sure you are sticking to that very contract, okay, or that written contract that the two of you have established. Because you are doing that so that you use that to track the client's behavior, and then when a client is acting out or is misbehaving, you draw the client's attention to the fact that there is a written contract in place that says that you are not supposed to do this, you are not supposed to do that. So you need to have a written safety or behavioral contracts with the clients. Then you identify those with what we call the splitting behaviors. So we said that those exhibiting splitting behaviors are those with what we call borderline personality disorder. So you need to, identify those with the splitting behaviors, and then you work around it because they can create problems among people. And then you assist the client to also deal directly with anger, how to manage their anger, encourage the client to participate in group activities and praise them, and praise non-manipulative behaviors, okay? Set boundaries, set limits to decrease manipulative behavior. You remove the client from group situations in which attention-seeking behavior occurs. So if you realize that the client is in a group therapy and then the client is behaving abnormally, or the client becomes more hostile, okay, you need to remove the client from the group therapy or the group. You provide realistic praises for positive behaviors in social situations. So where the client is able to, perform well and do well, you have to praise the client and let the client know that the client has done well. So that is on setting some of the interventions that we can put in place for clients with what we call personality disorders. And at this point, bring to an end the various types of personality disorders and how to care for them. If you have an input, have a question you want to ask, you can bring it on board. If I'm not able to give you a perfect response, I believe that other people are here who can help us also address the questions very well as well. Thank you. Before we go into my questions.
Hello, my question is in the chat box.
What is your question, Mr. Since you have muted, you are unmuted.
Hello.
Yes.
Yes, I was asking that it looks virtually the same like the OCD clients, like the signs and symptoms that the behavior they show. It just looks same as the client with what's the name autism.
Mm-hmm.
Then I was like how can I differentiate between these two? Like someone going through this OCD and then the autism, because they kind of have the same behavioral.
Now, okay. So behavioral, they mostly exhibit the same, but we know autism is more of, I mean, neurodevelopmental issues. Okay, they have issues with developmental. Okay, it's more of developmental issue, but OCD could be exhibited without the person. So you could, I mean, without you having a developmental problem. Okay, so yes, they have in autism, they have that, issue with social interaction, they have communication issues. And one thing too is that autism people, one key thing about them is, that repetitive behavior, that something like the banging of the head on the wall in order to draw attention. Okay, and like I said, autism, you can easily spot autism in the during the developmental stages of the child. Okay, so autism can easily be identified during early stage in life. But what we call OCD, mostly when the person goes up, person try to behave that ritualistic way, more perfectionist kind of behavior. I don't know if I'm able to, if I'm making sense here. Ms. Aisu.
Oh yes.
So
I got you.
yes, so autism is more of neuro issues. Okay,
The developmental aspect. Yeah.
Developmental aspect, you can easily spot that in the early stages of the child. But in OCD, probably later on the person will start behaving those kind of showing those kind of social issues and all that. Yes, there's a hand up, Madam Aman.
Yes. Sorry, I joined a bit late, but I wanted to find out where codependency will fall. Codependency.
No, that is on on alcohol, substance abuse. We do that one. Okay. It's not under, it's not actually a personality disorder. Codependency comes as a result of someone, let's say someone abusing drugs, okay, or let's say the person is abusing alcohol, and then someone who takes care of the person do everything in order to kind of make the one who is abusing the substance to become more comfortable. And so you the one doing things to kind of, let's say you are your partner, okay, and the partner abuses drugs, and you do everything to make the person still continue to abuse the drug. So when you behave that way, you have also so that is where codependency comes in place. So you are doing things to kind of, make the one who is now abusing the drug to continue to become abuser and then become more comfortable with his or her situation.
All right.
So it falls more under, falls more under substance abuse. Any further question input here? All right, let's look at this. During an assessment interview, a client diagnosed with antisocial personality disorder speaks, curses, and refuses to answer questions. Which is the most appropriate nursing statement to address this behavior? A, you are very disrespectful. You need to learn to control yourself. B, I understand that you are angry, but this behavior will not be this behavior will not be will not be tolerated. I think I jammed up the things up. This behavior will not be tolerated. C. What behaviors could you modify to improve this situation? D. What anti-personality disorder medication have helped you in the past? Who want to answer? You raise up your hand, you record, you come in, and then you also give us your response or your answer to it.
So, hey, you said we should raise our hands, so.
Madam Carol, let's go. What do you have for us?
Sorry, say I'll be a good student.
What do you have for us?
So you said so for therapeutic communication, as we learned yesterday, you need to acknowledge the patient's behavior and then you present reality. And also, maybe if you want to set your boundaries and all that, initially you can't just ignore the patient. You need to acknowledge the patient. So I am going for B. Understand that you are angry, but
Okay.
this behavior will not be tolerated. So it's like and the nurse acknowledge the client's behavior, and then I'm seeing some boundary setting as well in the statement.
Okay.
So for a personality disorder, I'll go for B.
Okay.
Thank
There
you.
was another hand. Madam Asian, you wanted to contribute.
Yeah, she already answered it. I was about saying the same thing. I'm going for B.
Okay. All right.
Yeah.
All right. Thank you. Is there another hand? Okay, Mr. Yusuf, you can come.
Okay, I'm just going to rule out A. I'm going to rule out A because they say you are very disrespectful. I think that is attacking the person, the client.
Okay. Mr. Yusuf is gone. Oh.
Yeah, that's it. I'm done. No?
Okay, so you were just taking the A out.
Out, leaving B,
Okay.
C, and D. Even though I also go for B with the same explanation.
Okay. All right. I think the answer has been shown. But now the I wanted to come in.
Yes, I wanted to give my input, but you've shown the answer, so.
Okay, don't worry. This question will
Thank you.
come to contribute. Okay. All right. So we all understand that the A best fits, the response that the nurse has to give to this very client exhibiting an antisocial personality disorder A. Okay. So we said that acknowledge the client feeling, set boundaries, set limits to the client. You need to be firm with your responses to the client as well. That is it. All right. A client diagnosed with antisocial personality disorder comes to a nurse, to a nurse's station at 11 p.m. requesting to phone a lawyer to discuss, filing for a divorce. The unit rule states that no phone calls are permitted after 10 p.m. Which nursing reply is most appropriate? A, go ahead and use the phone. I know this pending divorce is stressful. B, you know better than to break the rules. I am surprised at you. C, it is after 11, it is after 10 p.m. Phone curfew. You will be allowed to call tomorrow. D, the decision to divorce should not be considered until you have had a good night's sleep. Yes, Nana Priya.
Yeah, so please, I'll be going for option C. It says it is after the 10 p.m. phone curfew. You will be able to call tomorrow. So we made mention that with this type of personality disorder, when we set rules, we have to be firm on the rule that we've set. We don't have to let them, because they have manipulative behavior. So if we don't take care, they can say things to manipulate us. So we should be very firm and consistent when we set rules. So that's why I will be going for the option C. Thank you.
All right. She's going for B. Sorry, she's going for C, and she has given her rationale. Do we agree to that, or is there someone with an opposing view to what she said? Oh, yes, Carol.
Oh, sir. Sir, I just wanted to go through the possible answers. So A says, go ahead and use the phone. I know this pending divorce is stressful. This one is affirming the patient's behavior, which is wrong. Moreover, the patient is already an antisocial personality. So with this one, the patient will keep doing that same thing all the time. B, you know better than to break the rules. I'm surprised that this one is being judgmental. See, it is after 10 p.m. Phone curfew, you will be able to call tomorrow. This one, you have set the limits and you have also acknowledged the patient's concern. You give him the opportunity to call tomorrow. It's acknowledging the patient's concern. And then you are standing by the limit you are setting for the antisocial. And then the decision to divorce should not be considered until you have had a good. This one is ignoring the patient's concern, which is wrong in therapeutic communication. Thank you.
So I think can make progress. Yes, that is true. That the C is the best response here that the nurse has to give. You need to be assertive, you need to be calm, and then you need to set limits. There's a rule. So everybody needs to go with the rule. Consistency. So you need to maintain consistency in terms of applying your rules. Okay. Leave no one here. I've met questions on that several times. So leave no one would miss this kind of questions when we get. So that is it. A client diagnosed with paranoid personality disorder becomes violent on a unit. Which nursing intervention?
Sorry, boss.
Hello.
Which one was the answer? Was it the C?
Yes. So
okay, it's okay.
Yeah,
Thank you.
The C. Okay. All right.
Thank you.
A client diagnosed with paranoid personality disorder becomes violent on a unit. Which nursing intervention is most appropriate? We have A, provide objective evidence that violence is unwarranted. B, initially restrain the client to maintain safety. C, use clear, calm statement and a confident physical stance. D, empathize with the client's paranoid perceptions. I already have 2 hands. Let me see. Yes, Adepa, you want to come in?
Yes, sir. So I'm going to go for the B. Initially restrain the client to maintain safety, because they are saying that the client is being violent on the unit. You don't want the person to harm somebody before you, like you say, so you initially restrain to keep the other people safe. Or if there were to be like an option to say take the person out of the room or take the other people out of the room, then we'll go for that. But here, I think I'll do B.
Okay, all right, that's fine.
Thank you.
That's okay. That's what I mean, other part things. Okay, Madam Carol, is it okay? Okay, dropped it. Is Idrisu?
Yeah, I will go in for option C. You need to use clear, calm sounds and confident in physical in dealing with the patient with violence. Restraint should be the last resort when you come to psychiatric patient. So I think that in my point should be the answer.
Okay. All right. Going for C. There was another handout. Person has dropped it. Okay. All right. So have C, we have D. Yes, so just like inside this said, restraint should be the last resort. So
NCLES people, they are not serious, so because they said most appropriate. I was answering one Q bank, and then I chose something like this. They said most appropriate because there is harm, violence, like they are just confusing people left and right.
so in fact, restraining is the last resort. Okay. And so you have probably maybe there was something added to the question. I cannot speak best because I haven't seen the full question. Okay, probably maybe the client became violent. I mean, the nurse tried to calm the client down and the client was not, responding to that. So in that manner, you might need to resort to other interventions. Okay. But if that is your first interaction with your client, you don't go in what we call restraining first. Okay. So you have to use a clear, calm statement and be confident with your physical stance. Okay. So like I said, the question you met, I cannot really talk much about unless we have the full.
Okay, I'll find it and I'll get it to you.
So that we all look into it and see why they said that probably that the nurse had tried certain interventions and that did not work.
No, but that one, the patient didn't have a personality disorder. It was one of those the schizoid one, the schizophrenia one.
The schizo, okay. All right. But like we said, I mean, mostly restraint. We'll look at restraints and instances where we can restrain a client, okay, and then interventions for restraining that. Restraining is mostly the last resort when it comes to people or clients who are a little bit, violent, unless someone is actually in danger. Okay, and even before you restrain, you know that you need to have what we call an order in place before you can restrain, unless there is what we call danger in place before you can restrain that. And even after restraining, you will need a healthcare provider to come in and then use the go ahead to continue with your your restraining. Okay.
Okay, thank you.
Yes, Madam Carrie, your hand is up.
So the answer is C.
Is it the question on the screen?
Yes.
Oh, okay. I have not even read it out.
Oh, okay, sorry.
Don't worry. A highly emotional client presents at an outpatient clinic appointment wearing flamboyant attire, spiked heels. Sorry, spiked heels. Hey, who is making call and then let me use this. All right, this person. Spiked heels and theoretical makeups. Which personality disorder should the nurse associate with this assessment data? A, compulsive personality disorder, schizotypal personality disorder, C, histrionic personality disorder, D, manic personality disorder.
So, sir, can I continue?
Yeah, you can continue. You can continue.
So his histrionic personality disorder, you made us know that they dress flamboyantly to catch attention. They just want people's attention on them. So the heels, the attire, the makeup. See, answer is C.
All right. I think we all agree that it is C. It is histrionic. They always want to be the center of attention. They always want to do things, dress, dramatically seductive in order to kind of let people pay much attention to them. Okay. So that is histrionic personality disorder. We have a client diagnosed with borderline personality disorder, brings up a conflict with the staff in a community meeting, and develops a following of clients who unreasonably demands modification of unit rules. How can the nursing staff best handle this situation? A client diagnosed with borderline personality disorder brings up a conflict with the staff in a community meeting and develops a following of clients who unreasonably demand modification of unit rules. How can the nursing staff best handle this situation? A, allow the client to apply the democratic process when developing unit rules. B, maintain consistency of care by open communication to avoid staff manipulation. C, allow the client's spokesman to verbalize concerns during a unit staff meeting. D, maintain unit order by the application of autocratic leadership.
Hello, I think something is missing in the question, right? Because after develops.
This part of the question, I think so. I think but I mean,
Yeah.
but I think
Yes, after
we all
develops.
understand the what the question is trying to tell us. Okay, now it says that someone, like, we know, histrionic personality disorder, that they have, splitting kind of behavior. So this is typically telling us the client is exhibiting a splitting behavior where creating conflicts between what we call, staffs. Okay, and then it demands some form of modification with the rules in the unit. So they want to find out how can the nursing staff best handle this kind of situation. Okay. the question statement is not sweet. Yes. Myself, when I was reading, I was like, hey, when I was picking this question, is it that I didn't really edit my questions well? But that is the import of the question. So those of us who would want to contribute, I see you already answering the question. So meaning that, yes, the question is not sweet, but we kind of understand the question. Yeah, so you need to, maintain consistency in terms of your care, be open in terms of your communication to avoid manipulation. All right, so the B, like we're choosing, is the correct answer. So this is, someone with personality, a borderline exhibiting splitting behaviors. Okay, so you need to be very open with them, and then be consistent with what we call your care you are providing with them in order to avoid what we call the manipulative behavior. All right. We'll do one or two or some few questions and go to different topic or different areas. We look at the Alzheimer's and then dementia and all those areas as well. A client who was admitted for treatment of a personality disorder is observed pulling another client's hair and pushing clients out of their chairs. What is the priority nursing intervention for this client? A, removing the client from the room and addressing the behavior privately. B, establishing a therapeutic nurse-client relationship. C, placing the client in a jacket restraint. D, asking the client what purpose is served by disrupting others. This is also very straightforward. Right. I believe this question here is sweet for all of us. This question is sweet. So because it is sweet, let's come up with the sweetness part of the question, which is providing our answers. Yes, Madam Carol, go ahead.
He said, me, I'll talk if nobody is talking.
Nobody's talking, so talk for us.
So, I'll personally remove this patient from the other patients. I'll take the patient out because you said we spoke about safety. The patient himself needs to be safe. Other patients needs to be safe. So take the patient out of the room, and then you can address whatever you want to. You can address the issue there. If you leave the patient, he will continue doing that. So I'll go for A.
Okay. She's going for A, which is ensuring that you remove the client from the room and addressing the issue privately or addressing the client's behavior privately. And that is true, okay, even though my rationale is there, but like we all understand here that in this instance, you need to remove the client from the group for safety purposes, okay? And then you address the client's behavior privately. So the answer is A. This is a SATA question. The nurse is planning care for a client who has been diagnosed with antisocial. Yes, hello.
Yeah, boss, let me draw you back small. So let's take it this way. In case there is a possible answer that indicate that move the group away from, like, let's move the other clients away from the patient. Which one will you go in for?
Between which one? Like you have such
Between taking a client, yeah, there's a client which is
so between moving the client and moving the group. Is that what you are trying to say?
Destruction, I'm not call it, like the one we just choose the
Yes.
A,
So
where
if
we
I
move the
get you,
client away
if
from
I get you
the
very
thing.
well,
So
you're
if there
trying
were
to
to
say
be
that let's say you have the
an
option A
other
still
option
there,
that
and
indicate
you have another
that
option
move
where
the
the
group away
option
from
says
the
move the
client.
group out. Between moving the group and moving the client, which one you go for? Is that what you're trying to say? Hello, Ms. Idris.
Yes, I think that's what he's
All
trying
right. So to answer, between moving the client and moving the group, which will be more easier for us to do?
the
Move
client.
the
Moving
client.
the might
Right.
important.
Moving the client will be
Leave
the
the
most
stubborn
easiest.
academy.
I mean, moving the client to be the most easiest way for us than to say that you are
moving the client.
Yes. So you move the client because it will be more easier to take the client alone out than to say that I want to like lead everyone out. That might take some time. Probably by the time you end up, the client might have, end up causing a problem. So it will be more easier to move the client alone out and leave the what we call the group behind.
Yeah, so I think I've come across a person which states you should move all the other patients. That's when there's aggression, like severe aggression, or where there is danger to other
Yes,
other
maybe
clients.
client is very aggressive, very difficult to handle the client at that moment.
Yes,
Yes, I think yes. So in that instant, it might be very difficult for you to even hold the clients. So moving the group will also be much more easier, and leaving the client, much more easier. I hope we get what our sister is saying. In that very question, the client was more aggressive to the extent that handling the client was very difficult. And so in that instant, it will be more easy for you to move the group out and leave the clients behind. Yes, Madam Sarah.
Yeah, so concerning that one, so does it mean that they will lock the door behind the clients? Because the clients will follow if an aggressive client.
Oh, yes.
Will follow.
Yes.
Okay.
So you of course, after moving the other people out, when you leave the door open, clients will also follow you out. So
Hello, but
definitely, yes.
And then lock it
in that case, you can
you
is
are.
it appropriate
So that is why I was saying that no. So you mean that is imprisonment, or you are restraining the client? Yes. So yes, with restraining there is an exception. If the client becomes very violent, if the client becomes very violent to the extent that other people's life are in danger, you can restrain the client. Okay. No, you don't get to restrain, and then certain the criteria for you to restrain someone. Yes, you need an order to restrain the person, but at the moment when the person has become more violent and people's lives are in danger, you can restrain the client. But the moment you restrain the client, you need to have the healthcare provider coming in to have a written restraint order against that. So you are allowed to restrain when the client is more violent. But like I said, after restraining, just inform the healthcare provider for the healthcare provider to come in and then put the written restraint request down. Then you continue. The nurse is planning care for a client who has been diagnosed with antisocial personality disorder, which go address the client's antisocial behavior. They select all that apply. A, the client will share meals with others in the community dining area. B, the client will interact socially with others. C, the client will engage in individual therapy without disruptions. D, the client will take all medications as prescribed. E, the client will refrain from attention-seeking behaviors. There is a hand up. Mr. Yusuf, your hand is up.
Yes, A and B are out because we are dealing with antisocial. Someone.
Wait, you said A
and B, they are out.
A and B are
them.
out. So he's taking this and this out.
And then the client will engage in individual therapy without disruption. That's solitary distance. So that one is there. C.
Okay.
But D, I don't know whether the client will take all medication as prescribed. So that's
you are thinking about this word and all right. Okay.
All medication. So the client will refrain from attention-seeking behavior. Okay, yes, that one.
So you go for this.
C and E.
So he's going for the C and E. Okay, fine. Let's look at someone else. Madam Sarah, your hand was up.
Yeah, so I will go for, because the question is asking for the goal to address that antisocial behavior. It means we want to correct the behavior. So the client will share meals with others in the community dining area. Usually the antisocials will not like to be part of a group. So if we want to reverse that behavior, it means that they will have to share meals with others. So I'll go for one. And then B2, the client will interact socially with others. So we are expecting that by the end of the treatment, the client should be able to interact socially because they have the antisocial behavior. And then C, the client will engage in individual therapy without disruption. This one will encourage his antisocial behavior, so we won't take it. Then the D, the client will take all medications as prescribed. So with the antisocial, they have a deviant behavior. They will decide not to take the medication. So our goal is for them to take their prescribed medications. And then the clients will refrain from attention-seeking behaviors because they are deviant in a way. We will try to let them refrain from those behaviors. So I'll go for A, B, D, and E.
Okay. That is what Madam Sarah is going for. Is there anyone with an opposing answer here? Hey, why is it that for this very question there, the answers are not coming in the comment chat? I'm not getting it in the comment chat. Okay.
Hello.
Yes.
Hello.
Yes.
Yes, I think that yeah, this is Yusuf.
Yeah, go ahead.
Yes, I think that she's right because myself didn't look at the modifying phrase very well, which goes address the client and social behavior. So I love the way she has answered it.
Okay. The answer is A and B. So so let's go back to the question. Let's go back to the question. The A says that the client has ceased manipulative behavior. No, this is the question. The client will share meals with others in the dining area. B is the client will interact socially, right? Is medication about social behavior?
No, but sir, they have deviant behavior. So these people,
we are not talking about. I mean, the question is targeted towards a certain area. Okay, which goals address the client's antisocial behavior? You get it? So we are looking at
their name is antisocial. So.
Yes. So we are looking at like social areas. Okay. The clients, in terms of the client's social interactions, those areas. And even, is it the option D, the or there makes it wrong? This is an absolute sense, the option D. It makes it wrong, even though the client will take the medication. Is it everybody that will take all their medication? People who are very deviant, have a deviant behavior, you give them the medication, you might not even. So the or there makes even that option wrong. And like I said, it's not also more targeted towards the social behavior of the
with the all thing. Sometimes I guess it's confusing. I was reading the ophthalmic, the glaucoma, and the cataract people, and our patient teaching is to allow them to follow all appointments.
Yes, that is different. All appointments. Like encouraging the client.
When you see the all, it means that some all gives yes.
Yes. So it's not all instances. It's not all instances that
so
makes
when will
the
you know
statement
that
wrong. Now let's stand on the point you have. That it says that clients should follow all appointments. Okay. So it's like encouraging the client to adhere to follow-up visits or follow-up care. That is what that statement means. Now, when it comes here, this very odd here is telling you that the client should take all their medications. Now, zoom it to these very people with these issues. Okay, personality behavior, more stubborn people and all that. Do you think that they will take all their medication? That is one thing you should ask yourself here. And like most instances, they're all, I mean, if you have an options with all inside it, more of the time, those options are mostly wrong. And they will tell you that the all there is an absolute statement, and that is what making that option to be wrong. I understand the point you are making, but sometimes you need to consider the question. You need to look at where the question and then you look at the options. That's why I say that when it comes to when you're answering NCLEX questions and then you are trying to use strategies, you might sometimes get it wrong with your strategies. So sometimes understand the question and then apply your strategies perfectly. Okay. Then the last one that I might, if I was to be the one, I might add it that the client will refrain from attention-seeking behaviors. This is more towards the client. Okay, attention-seekings are like personal things. It is not more of social thing. So the socials are like the client reacting with people, the client going out to eat with other people. That is social. I hope you get it. There is a hand up. I think this one. Yes.
But
Wait, one after the other, one after the other. Let's Preska, you can come in, then Rahma will come
boss,
in.
what I really want to understand the question because I'm not getting it.
You are not getting the question.
Yes, I don't understand the question.
Okay. All right. I'll try to explain. Let me hear from Madam Rahma. Yes. Can you? Your voice is far behind. Hello.
Hello.
Yes, your voice is far behind. I'm struggling to hear you. Hello.
Hello.
Yes. Yeah.
Please,
You can.
is it okay?
Yeah, it's okay now.
When we started with this personality disorder, you said we have cluster B, and under cluster B we have antisocial personality.
Yes.
And those people, remember, you said they are they don't obey laws.
Yes.
They are law breakers.
Yes.
So in this question, is this antisocial different from the one under cluster B? Or this one is antisocial, like antisocial people? They don't like to associate with
No,
people.
it's the same. It's an antisocial personality disorder we discussed under cluster B.
Because if it's 6 o'clock medication and when it's 6 o'clock, they won't come.
Madam, I'm saying that it's the
treatment.
same. Is the same antisocial personality we talked about. Hello, is she with us?
Hello, then I'm a little bit confused here.
Why are you confused? If
like
you can,
their behavior, their behavior is solely like we didn't. Okay, I don't know if I didn't hear anything like socialization in those groups.
Yeah, so
what I know about them is they don't obey laws.
Yes, they
and
don't
they are
obey laws.
manipulative.
Manipulative, very well. And then their social relation with people is also poor.
Okay, maybe I didn't get that part.
Yes, they also have issues with, social relationship or interpersonal relationship with people. That is also another concern. That is also characterize them. That yes, they have that manipulative behavior. They have that, law abiding. They don't want to abide law, and then that kind of behavior. And also that alone, pushing them away from engaging with people. So they also have that kind of social, problem where they have to relate with people. That is where, so someone was asking that doesn't understand it. So the question is saying that someone with a personality, antisocial personality disorder. Now the question is that what the question wants us, we want to see things that if the client is doing that, it means that, the client's, it indicates success in terms of the client's social behaviors. Okay, or the client's antisocial behaviors. So
Did
when
you say it's like you are you are doing something that will improve his condition, all right?
Yes, they are the client's social condition. That is the attention of this question, or what the question wants. So the question is that which goals that will indicate that you are able to address the client's social behaviors. So we are not looking at the client's entire problems. The question is only centering on the client's social behaviors. The social behaviors here, we are talking about mainly, interaction with people, how the client mainly relates with people socially. That is the meaning of, the question. If you want to understand the question, if you break down the question, that is what the question is trying to tell us. That we are looking at the client's social, areas. What are some of the things that if the client is doing, it tells us that the client has achieved certain form of successes in the client's social, interaction or social behavior.
No, but I was thinking that the addressing the client's antisocial behavior was meant to describe the client's antisocial behavior. Like if this
Generally.
client is doing something, then you see that, oh, this person is exhibiting antisocial behavior.
No.
Okay.
Yes, there was another hand. Yes, Obapame.
Yeah, but like I think you've made things clear now, but the little that I want to add is this question is kind of
You've gone off. Adame, you've gone off.
yeah, I was saying that this question is kind of portraying the characteristics of antisocial behavior of this particular client. So what a typical antisocial behavior client would do is what this question is asking from us, what typical this particular person would do. And the others, when we see the other options, it's not likely, it will not likely happen that antisocial personality will easily. Please, can you go back to the question?
This is the question.
Yes, like option C, the client will engage in individual therapy without disruptions. This will rarely happen. They don't easily engage with others during and the option E, the client will refrain from attention-seeking behavior. They seek attention. They don't refrain from it, from seeking attention. So it's kind of portraying what should I put it? Like their actual behavior, what they will do for you to identify them that this person is antisocial. That's how I understand it anyway.
Yeah,
Yeah.
that's exactly how I understood it too. So she made my
Sarah.
Okay, hello, sir.
Yes, hello.
Yeah. Can I come in?
That's
Like,
okay, you
this
go
is
ahead. I
Regina.
still have hands up. Okay, go ahead.
Okay. So,
Regina.
as you rightly said, our main goal is to address the antisocial behavior in this question. So,
Yes.
if someone is antisocial, these people, they are withdrawn, they don't socialize, they don't want to mingle. So, the only options that will address that behavior is that the client will share meals with others. They
Sure.
could see that now is getting to communicate with others. But
Yes.
then the last option, the client will refrain from attention-seeking behaviors. I think these personality people, because they are withdrawn, they are on their own, they don't want to mingle,
no.
wouldn't want to seek attention of others. So, in a nutshell, it wouldn't be part of the solutions to address the antisocial behavior than the first two.
The first two, exactly.
They are getting interactions with others.
All right. Yes, I think Madam Regina has give us a perfect explanation. I still have about 6 people hands up. Now the 6 want to
Because I mean,
Say, I mean, I think let me come in.
Hey, wait, let's do it one after the other.
okay.
Yes,
So
Madam,
my own has to do with the D.
Mr. Yusuf, then Madam Mary, Mr. Yusuf, let's go.
Okay, my own has to do with the D.
The D.
When we
Okay.
yes, when we remove D, saying because they use all, and then someone asks a question. So I think we should consider when will is used and then should, because here they say the client will. So that means that the healthcare provider is gauging that the client will do it. Different from the example that should. That means should. That means that you are now seeking that the client will do it.
Yeah. So,
So
the client should attend or should go his all his or her medical appointment or something like that.
So that means that you are now seeking. It is not a judge. So when you judge and say that the client will do it, what if the client doesn't?
Okay, thank you. So Mr. Easy was just we are playing with the words here. Madam Mary.
Thank you very much. I'm thinking that the question is talking now. You know, when you are caring for a client, everybody have an objective you have to meet.
Yes, sure.
The people, they don't like associating with others.
Yeah.
So when they try to associate with others, you the nurse, as you are caring for the fellow, what are you trying to achieve?
Sure.
So the A is what the nurse want to achieve. And then you want the client to mingle with others. So how will she mingle? By sharing food with others, by interacting with others. So that is the A and B. Why is that of the C? They are saying that the client will engage in individual therapy without distractions. That was already the original character of the client when you diagnose the social. So that one is not an objective. You cannot achieve that one. Meaning you haven't still solved the client's problem.
Okay.
Then the client will refrain from attention-seeking behavior. There are not people who seek for attention, so there's no even listening that they should refrain from. They are antisocial. They don't want to mingle with anyone, so they don't even want to seek attention where people want to associate with them or something. So I think the E is out, the C is out. Is the D that I wouldn't have been too sure, but as for the C and the E, they are what? Signs and symptoms of how an antisocial client will be. And you, the nurse, as you are not taking care of the client, what do you want to achieve? The A and B will now let you know that, oh, I've really met my goal or I've met my objective. Thank you.
All right, I think we can make progress. Let's make progress. Thank you all. Those of you who wanted to contribute. Sorry, I think we'll go to other questions and then you can come in. But the question has been well elaborated on. I mean, before try to get better understanding. But if you look at the question, I mean, we are looking at areas where the client is achieving successes in terms of caring for the client. And the A and B is the perfect answer, or the most appropriate answers here. Okay. But I wanted to do something also. I never thought that it will take us out to this end, but we have some few minutes left as well. The nurse is providing care to a client who has been diagnosed with a personality disorder, which findings indicate that the treatment plan has been beneficial for the client. A, the client has ceased self-manipulating behavior and bath once a week. B, the client eats sporadically and then reports being told she does not deserve to eat. C, the client asks others for money because the client's money was stolen. D, the client sits with others in the lounge area and conversing about current affairs? This is very simple, straightforward question. Esther, is it to this question? And let's go. When Esther is ready.
Okay, so sir, please, I'll go for the option D. The client sits with others in the lounge and lounge area conversing about current affairs. So that shows an improvement. The other options, I think, is not appropriate because the client has ceased self-mutilating behavior. That one is good, but then the other side, but once a week is way, even once a day cry will not be considered. How much more? So that one is making the option wrong. Yes. And then the B, the client eats periodically and reports being told she does not deserve to eat. So I think the B part is also making it wrong. And then the client asks others for money because the client's money was stolen, which is not the right thing to do. If your money is stolen, you have to report to the appropriate authorities. You don't have to go around asking other patients for money. So that's why I chose the option B. Thank you.
That is correct. So she has given us a perfect explanation. And I think we all agree to that. Okay. I think it was left with some few questions, but that is okay. So this is what I wanted to do next. So the answer was D to that very question. This question, the answer was D. Answer was D. That is the perfect explanation she gave. So I wanted to do the cognitive disorder. So apparently we are almost done with, or we are done with. I mean the psychotic areas. We're done with the personality disorders. We're done with the non-psychotic conditions, anxiety, and all those things. We did some weeks or some the last 2 weeks or so. So I wanted to today touch on what we call the cognitive disorders, mainly dementia, and then we also talk about Alzheimer's disease. But I don't know, time is not on our side, but I'll just touch on it briefly so that next week when we meet, we try to continue and then finish with it. So when it comes to dementia, okay, we all know that dementia is a syndrome with what we call progressive deterioration in what we call intellectual functioning, secondary to structural or functional changes in the brain. So when someone has any form of structural or functional changes within what we call the brain, this affects what we call the person a level of intellectual functioning in terms of memory, thinking, and all that, problem solving, abstract thinking, all becomes affected. Now, I believe that as a student of NCLEX, one thing you might have come across it most of the time is the difference between dementia and delirium. And you have to be able to differentiate between dementia and delirium. It's very simple. Dementia, it's more of long-term problem. So you have the causes mostly being as a result of, there's a progressive decline. So it's more of a chronic issue. So there's a progressive decline in cognitive function, mostly caused by what we call brain damage or diseases. And then it is also irreversible. Dementia is irreversible. But when you take delirium, it's mostly sudden, more acute, and then it's more so temporal, so it is reversible. So we said that dementia is reversible, it is more progressive, that is more chronic, mostly as a result of brain damages or brain cell damage. Whereas delirium is more of sudden acute, or it has acute or sudden onset. And then the problem is more temporal, where the person loses what we call memory. The person recovers fully. Mostly the person will recover. And the cause of it is mostly as a result of underlying medical conditions. So it could be people with DM, And we know, especially females, UTI is one of the most common cause of delirium. Okay, UTI can easily lead to what we call a certain form of abnormal or person having certain deficit in terms of problem solving as well as behavior. So delirium has a sudden onset. It is temporal. It is reversible. Mostly the cause of it is as a result of an underlying medical condition. It could be dehydration, can equally lead to infection, and it can all lead to, or the use of substances. Let's say the person goes to take drugs and start to misbehave, or start to have certain form of deficit in terms of memory. Whereas dementia, like I said, is more progressive, mostly as a result of damage to brain or to the brain, and then it is irreversible. Okay, so the long-term and the short-term memory loss occurs with what we call dementia. So they have what we call amnesia, okay, where they tend to forget about things. Then they have memory or impairment in judgment. Abstract thinking becomes a problem. They have problem-solving abilities and then behavior. Dementia mostly results in what we call self-care deficit. Okay. Taking care of themselves becomes a problem. So we'll look at what we call Alzheimer's disease. We'll look at the various stages of Alzheimer's and then level of functionability of the individual. So you realize that as the person progresses through the stages of Alzheimer's, the person's ability to function becomes affected. So they tend to have self-care deficit. Then dementia-like symptoms can be as a result of physiological condition, and such conditions must be ruled out initially. So that is where delirium comes in. So if the cause is as a result of what we call physiological, condition, like dehydration, like I was talking about, like, UTI or any other medical condition that causes the individual to behave abnormally and tends to have memory deficit. Hey, who is playing us? Who is giving us? Dan Vivian is giving us music, and let me mute it. All right. So the person, you need to rule out the delirium, okay, before you can say that it is dementia, because aged people tend to have certain form of delirium, and you might think that it is dementia, especially the aged UTI is one of the common cause of what we call delirium and what we call the aged people, as well as certain sepsis or infection can equally lead to that. So you need to rule out what we call those physiological causes. The most common type of dementia is what we call Alzheimer's. Okay, so when you take NCLEX, you cannot be a student of NCLEX and say that I didn't learn about Alzheimer's when I was going to write my NCLEX. You need to understand Alzheimer's. You need to look at the various areas in terms of problems that people with Alzheimer's disease mostly encounters, wandering, sundowning, and then all those areas, so that you know how to manage the clients in that regard. And so because we are saying that the most common type of Alzheimer's or most common type of condition, or the kind of medical condition or condition that mostly leads to what we call dementia is Alzheimer's, then that means that we have to talk about what we call Alzheimer's disease. And that brings us to, Alzheimer's disease. So we'll talk about Alzheimer's disease and we'll look at the various types of Alzheimer's disease and the stages of Alzheimer's disease, and then what characterize them, and then in terms of functionality, what they are able to do and what they are not able to do. So Alzheimer's disease is irreversible. So that is what we're saying, that the cause of their memory decline is irreversible. And so you realize that as the person progresses through the condition, the decline will continue, and then the person will not be able to recover fully and then be able to function as they used to function. So it is an irreversible form of senile dementia caused by nerve cell deterioration. So there is nerve cell deterioration that is causing the person to exhibit those dementias or memory problems. Individuals with Alzheimer's disease experience what we call cognitive deterioration and progressive loss of ability to carry out activities of daily living. So mostly their major areas or their major problem is activities of daily living. That is where they mostly encounters the problem. The clients experiencing a steady decline in physical and mental functioning, and usually requires long-term care in specialized facility in the final stages of the illness. So just like I said, these people tend to decline in terms of their memory, and then the decline is also gradually as they progress through the various stages. And so at the end of the day, these people might require or will need a long-term care facility to take care of them in decision making, self-care area, and all other part of their basic needs. They will need specialized facilities in terms of long-term care. When it comes to the stages and major characteristics of what we call Alzheimer's disease, we have stage 1, which is mild, which is characterized more of forgetfulness. And then stage 2, we'll go into I'll go into each stages with that so that we can understand the various characteristics very well. So when you take what we call the mild stage, okay, or the first stage, they mostly have issues with forgetfulness. And so mild memory problems occurs, that's forgetfulness. They have difficulty in finding the right words. They occasionally get confused. They have subtle changes in personality or behaviors. Now, when it comes to the area of functionability for people with Alzheimer's disease in the first stage, the individual can still function independently. So at stage 1, they can function independently in daily activities, but they may experience challenges in terms of complex tasks and planning. And so for stage 1, that is the early stages of what we call Alzheimer's disease. They have what we call issues with memory, that is forgetfulness. They sometimes find it difficult in terms of finding the right words to describe whatever their problem is. And then when it comes to areas of functionability, they are able to maintain mainly, almost everything in terms of self-care. They are able to do everything independently in terms of daily activity. However, things that requires or complex activities, that is where sometimes they experience what we call difficulty or challenges in performing complex tasks or planning. The stage mostly lasts for several years, so the individual can be within the stage 1 or the mild stage for a very long time or several years before especially the person is getting the needed support. Okay, it is when the person is probably not getting the needed support and the person is left alone, that is where the person is likely going to progress faster to the second stage. Then we have the stage 2, which is the moderate stage. Okay, stage 2, which is the moderate stage. The symptoms here, or what the client mostly shows, is they are more confused. So confusion is more evident here. Confusion is there. They have more pronounced memory loss. They have difficulty with what we call language and challenges with recognizing familiar faces or places. Now, when it comes to the area of functionability, the individual may need help with what we call the activities of daily living. Okay, so when it comes to the area of functionability for people with moderate or stage 2 dementia, they would need what we call certain form of help, okay, in completing what we call activities of daily living, such as bathing, dressing, and then preparing for meals. It often lasts longer, okay, in terms of, it is the longest in terms of the stages. So the individual can remain in the stage 2 for the rest, or can remain there for a very long time. Okay, so when you look at the stages, in terms of which of the stages that the person lasts longer, it is the stage 2 or the moderate phase. Then we have the moderate to severe phase. Moderate to severe, that is stage 3. So stage 3 is moderate to severe. Mostly, that is ambulatory dementia. They have significant loss of memory and then cognitive ability. So, significant loss of memory and then cognitive ability. So at this point, the individual, in terms of ability to think, memory, make decisions, choices, take care of him or herself, the person, it deteriorates. So there's significant loss in those areas. And then the difficulty with communication also happens here. They have, profound personality changes. So they start to misbehave or behave abnormally. Things the individual can do or functionality the individual require full time to take care of. So these people, when they are in stage 3, their ability to function, is deteriorated. It's not there. So you might have to do that for them. So they require full-time care and then may experience behavioral issues like wandering, agitation, and then they may hallucinate. So at stage 3, hallucinations can also occur at the stage 3 as well. Now, when you take what we call the stage 4, that's the last stage. That means that the person is gone. Okay, so nothing can be done at all about the stage 4. So these are what we call the various stages. Stage 1, we said that the person has issue with, mild forgetfulness, or that is mild stage 1. Forgetfulness is there. The person is able to, perform activities of daily living, unless things that requires complex, tasks or complex thinking or complex tasks. That is where the person will need help. With stage 2 or the middle stage or the second stage or moderate stage, the individual has what we call profound or pronounced memory loss, difficulty with language, and then certain form of having issues with recognizing familiar faces. When it comes to ability to function, they are able to they may need help with daily tasks like bathing, dressing, and then preparing for meal. Okay, they may need help, some form of help. Then when you take the stage 3, that is where there is moderate to severe. At that point, you have to do everything for the individual. So most pronounced memory loss, difficulty with language, and then they have significant memory loss, and then cognitive ability changes. You need to help them in terms of how to communicate. They have issues, and then personality changes. They tend to hallucinate. They wander around at stage 3, and then agitation also occurs. At this time, you have to provide the individual full attention in terms of the care. At the stage 3, or the last stage is the stage 4. That is the end stage. The person is probably going. Okay, so that is the various stages of what we call Alzheimer's disease. In terms of the problems they do encounter, the memory problems, that is, they have agnosia, that is failure to recognize or identify familiar objects despite intact memory function. Sorry, despite sensory function. So they have issues identifying what we call familiar, objects or familiar, recognize or identify familiar objects. That is agnosia. Then they have amnesia, loss of memory caused by brain degeneration. And then they also have aphasia, that is the language issue. We said that stage 3, they have language problem. So language disturbances in understanding and then expressing spoken words. Then we have aphasia, inability to perform motor activities, despite intact motor function. So these are what we call the various memory problems and then areas that they do have challenges. I think I would like to end it here for today. Okay, the sound downing is I mean it's pronouncedly in you know the sound downing is part of wandering, so it's at stage 3. Okay, sound downing is part of what you call wandering, so it's at stage 3. Okay.